Kesehatan adalah sebuah isu global yang perlu komitmen seluruh bangsa, termasuk Indonesia, guna mempertahankan masa depan sebuah bangsa. Indonesia sebagai negara kepulauan terbesar dengan jumlah penduduk terbesar keempat di dunia, mengambil peran strategis dalam membangun kesehatan bagi masyarakat dunia. Kesehatan adalah sebuah isu global yang perlu komitmen seluruh bangsa, termasuk Indonesia, guna mempertahankan masa depan sebuah bangsa. Indonesia sebagai negara kepulauan terbesar dengan jumlah penduduk terbesar keempat di dunia, mengambil peran strategis dalam membangun kesehatan bagi masyarakat dunia. Terletak di Jawa Timur, dengan suasana akademik yang mendukung, lingkungan yang nyaman dan menyambut hangat, Malang telah menjadi salah satu tempat yang paling pendidikan tinggi dalam ilmu kedokteran di Indonesia dan diperhitungkan di Asia Tenggara dengan visi menjadi perguruan tinggi pelopor dan pembaharu dengan reputasi internasional dalam ilmu pengetahuan, teknologi, seni, dan humaniora, terutama yang menunjang industri berbasis budaya untuk kesejahteraan masyarakat. Fakultas Kedokteran menjadi salah satu fakultas pilihan utama dan terus menorehkan prestasi dengan komitmen pada keunggulan dan inovasi. Berawal dari Sekolah Tinggi Kedokteran Malang, didirikan pada 14 September 1963, Fakultas Kedokteran resmi menjadi bagian dari Universitas Brawijaya pada tanggal 14 Januari 1974 dan telah melalui 15 Sejak berdiri dengan satu program pendidikan dokter, FKUB terus menjadi pelopor pengembangan pendidikan spesialis dan profesional kesehatan lain. Hingga tahun 2020, FKUB telah berkembang menjadi 6 jurusan, yaitu kedokteran dan pendidikan spesialis, keperawatan, gizi, kebidanan, dan farmasi dengan 33 program studi yang telah mendapatkan pengakuan baik dengan sertifikasi internasional dari AUNQA, ASEAN University Network Quality Assurance, maupun akreditasi unggul dari LAMPTIKES, Lembaga Akreditasi Mandiri Pendidikan Tinggi Kesehatan. Didukung oleh 402 dosen dengan 18 profesor dan 19 lektor kepala. Setiap tahun FKUB menghasilkan 7.081 lulusan yang menjadi bagian dari sumber daya manusia kesehatan Indonesia dan mengabdi di penjuru Nusantara. Berkomitmen meningkatkan kualitas hidup masyarakat demi kemajuan Indonesia yang lebih baik melalui kolaborasi interprofesional, proses pendidikan di semua jurusan, mengedepankan integrasi pengetahuan, keterampilan, dan keahlian dalam suasana akademik yang kondusif. Keenam jurusan, kedokteran, pendidikan spesialis, keperawatan, gizi, kebidanan, dan farmasi terus berkembang melalui pendidikan, penelitian, dan pengabdian masyarakat.
Inilah jurusan kedokteran yang merupakan salah satu jurusan di Fakultas Kedokteran Universitas Brawijaya. Jurusan kedokteran ini aktif melakukan penelitian dengan melibatkan dosen-dosen serta penerbitan jurnal serta melakukan inovasi-inovasi. Sampai saat ini jurusan kedokteran telah berhasil mencetak tenaga dokter yang tersebar di seluruh pelosok Nusantara dan luar negeri. Kedepannya jurusan kedokteran juga akan menjalankan suatu sistem yang baru yang disebut sebagai SIMBA, yaitu suatu sistem informasi manajemen berbasis akreditasi.
Kekurangan dan distribusi dokter spesialis tidak merata di Nusantara menjadi dasar pengembangan program studi pendidikan dokter spesialis dan subspesialis berfokus pada ethical conduct, keterampilan riset klinis dan biomedis yang berpihak pada kebutuhan pasien menjadi keunggulan lulusan program studi pendidikan dokter spesialis dan subspesialis di FKUB.
Jurusan Keperawatan Fakultas Kedokteran Universitas Brawijaya berkomitmen mendidik mahasiswa menjadi seorang perawat profesional yang memiliki daya saing di tingkat regional, nasional, dan global melalui pendidikan kesehatan berbasis inovasi dan pelayanan kesehatan. Satu hati mengabdi, satu jiwa merawat bangsa.
Jurusan Gizi Fakultas Kedokteran Universitas Brawijaya memiliki visi yaitu menjadi institusi pendidikan di bidang gizi manusia yang bermutu internasional pada tahun 2027. Dalam upaya untuk mencetak lulusan nutrisionis dan dietitian yang unggul serta mampu berkompetisi baik nasional maupun global, kami berusaha menjaga mutu pembelajaran, menyediakan fasilitas sesuai dengan standar yang telah ditetapkan, meningkatkan mutu dari tenaga pendidik, serta menjalin kerjasama, baik kerjasama nasional maupun internasional.
Berawal di tahun 2009, pengembangan jurusan kebidanan menjadi bagian dari komitmen fakultas untuk mendorong pendidikan tinggi, mencetak sumber daya manusia kesehatan di bidang kebidanan. Kami juga selalu aktif melakukan riset, publikasi nasional maupun internasional, dan terus berupaya mengembangkan secara bersama sifatnya nasional maupun internasional dengan melakukan kuliah online, joint research, dan pengabdian masyarakat.
Departemen Farmasi terdiri dari dua program studi. Pertama adalah S1, Sarjana Farmasi, dan kedua Apoteker Profesional Program. Departemen Farmasi saat ini berorientasi pada clinical farmasi dan komunitas farmasi, tapi ke depan kita akan melanjutkan ke arah drug development, biofarmasetik, dan small molecule dan delivery system.
Fakultas Kedokteran terus memantapkan diri menjadi fakultas yang unggul dan berkomitmen menjadi institusi pendidikan kedokteran dan kesehatan yang terkemuka dan bertaraf internasional. Komitmen tersebut didukung dengan kelengkapan dan pengembangan sarana prasarana pembelajaran yang modern dan berbasis teknologi informasi. Di antaranya, Computer-Based Laboratory, Skill Laboratory, Anatomy Museum, Animal Lab, Biomedical Lab, Nutrition Lab, Tim Emergency dan Disaster TED. Proses pendidikan profesional kesehatan di FKUB didukung oleh Rumah Sakit Pendidikan Utama dan jejaring yang menjadi bagian dari sistem pendidikan serta pelayanan kesehatan. Di antaranya, Rumah Sakit Saiful Anwar yang telah mendapatkan penghargaan akreditasi internasional bintang 6 oleh Komisi Akreditasi Rumah Sakit Indonesia. Rumah Sakit Universitas Brawijaya menjadi satu dari rumah sakit perguruan tinggi yang telah terakreditasi paripurna. Rumah Sakit Daerah Dr. Iskak Tulungagung yang menjadi pelopor pengembangan jejaring sistem pelayanan emergensi berbasis masyarakat yang terintegrasi melalui program Public Safety Center dan telah mendapatkan award dari International Hospital Federation. Tidak hanya berkomitmen pada keunggulan akademik, FKUB juga mendorong prestasi mahasiswa sesuai minat bakat dan penalaran yang didukung dengan program pengabdian masyarakat.
Kami berkomitmen untuk menciptakan kegiatan bagi mahasiswa yang senantiasa mengutamakan aktivitas meningkatkan kemampuan dalam proses berpikir secara nalar dan kemampuan analisa, baik pada kegiatan kurikuler, co-kurikuler, serta ekstrakurikuler, serta selalu berfokus pada pengembangan profesionalisme berpedoman pada etika dan interaksi yang baik dalam hubungan multidisiplin profesi juga terhadap pasien. Menjadi kebanggaan dan kebahagiaan kami bahwa mahasiswa FKUB terus menunjukkan prestasi dalam ajang nasional, internasional, serta bakti kepada negeri seperti aktivitas FKUB mengajar, desa binaan, serta praktek kerja nyata mahasiswa terintegrasi demi tercapainya kompetensi serta pengabdian juga mendekatkan diri kepada masyarakat.
Fakultas Kedokteran Universitas Brawijaya menghasilkan lulusan di bidang kedokteran dan kesehatan yang beriman, bertakwa, berakhlak terpuji, dan memiliki profesionalisme sehingga mampu mengabdi pada bangsa dan memiliki keunggulan kompetitif pada skala nasional maupun internasional.
Halo, nama saya Manarul Iman. Saya mahasiswa FKUB Angkatan 2017.
Perkenalkan, nama saya Ulil Afla dari jurusan Ilmu Keperawatan 2017.
Nama saya Hazrina Putri, mahasiswa jurusan
Ladies and gentlemen, we will start the event in 5 minutes. Please be seated. Assalamualaikum warahmatullahi wabarakatuh. To the Honorable Dr. Wisnu Berlianto, Pediatrician Consultant, as the Dean of the Faculty of Medicine, Universitas Brawijaya, to the respectable Dr. Tita Haryanti, MKes, as the Head of Master Program of Hospital Management, Universitas Brawijaya, to the honorable panelists, Dr. Kohar Harisantoso, anesthesiologist, consultant, Dr. Viera Wardani, MKes Fiskwa, Dr. Andes Ali Jamhuri, AKM Com PhD, Mr. Tito Hari Pradianto, STMT, Professor Dr. Ahmad Rudianto, internist consultant, and Dr. Istan Irmansyah, orthopedic consultant. And last but not least, to the distinguished participants and beloved friends. Good morning, ladies and gentlemen. My name is Sabrina Aulia Rahma. It is an honor and precious chance for me to be the master of ceremony in this morning on Wednesday, 23rd of March, 2022. In our valuable event, the result, dissemination of student outbound programs with the topic hospital strategy to achieve sustainability, looking toward saving tomorrow resources. First of all, let us thank to God who has been giving us mercy, guidance, happiness, and healthy, so we can attend and participate in this event without any obstacles. Healthy and wealthy, hopefully, will always be given to us in this event. Before we start the event, please allow me to read the agendas that we will have today. First, opening. Second, the opening speech from the Dean of the Faculty of Medicine, Universitas Brawijaya, Dr. Wisnu Barlianto, Pediatrician Consultant, which will be followed by the speech from the head of Master Program of Hospital Management, Universitas Brawijaya, Dr. Tita Haryanti, MK. Third, pray. After that, we come to the main agenda, which is presentation. The first session presentation will be delivered by Group 1, Group 4, and Group 5. The discussion of the first session will be conducted right after the first session presentation finishes. We will have the panelists to give feedback and also the forum to have the discussion. Next, we will have second session presentation from Group 2 and Group 3, and will be directly followed by the discussion by the panelists and also the forum. And the last is closing. Ladies and gentlemen, without further ado, we will have the opening speech from the Dean of the Faculty of Medicine, Universitas Brawijaya, to Dr. Wisnu Barlianto, Pediatrician Consultant. Time is yours.
Thank you for the chance. Assalamualaikum warahmatullahi wabarakatuh. The Honorable Head of Magister Hospital Management, Dr. Tita Haryanti, the Honorable all of the panelists in this seminar. First of all, let us thank Allah, the God of Merciful. Because of His blessing, we can meet here today. A few weeks ago, the study program of Master of Hospital Management held an online hospital visit to the Theptain Hospital, Thailand, and the National Taiwan University Hospital. Today's seminar is the final part of the student outbound program, where we can discuss what has been learned from the hospital visit. The seminar term, Hospital Strategy to Achieve Sustainability, Looking Toward Saving Tomorrow Resources, are divided into 5 interesting subtopics, including healthcare policies and regulation, hospital building, clinical governance, quality of care, and finance. These aspects are essential in formulating the best strategy for implementing hospital or healthcare sustainability. I hope today's seminar will bring many benefits for the student of MMLS and all the participants. I sincerely hope you all enjoy this seminar. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much to Dr. Wisnu Barlianto, pediatrician consultant, for the valuable speech. Hopefully this event will bring benefit to all of us. Next, let's welcome our beloved Dr. Tita Haryanti, MKes, as the head of Master Program of Hospital Management, Universitas Brawijaya, to give the speech. To Dr. Tita Haryanti, MKes, times is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. First of all, on behalf of Hospital Management Master Program, I would like to welcome all of you to our roadshow and hospital visit dissemination. I'm very thankful to the Dean of Faculty of Medicine, Universitas Brawijaya, all speakers, to the panelists, Dr. Kohar, Prof. Rudi, Bapak Ali Jamuri, Bapak Tito, Dr. Istan, Dr. Viera, and CEO of Kaptarin Hospital Thailand and also National Taiwan University Hospital for taking time out of your busy schedule to attend this event. I would also express my sincere appreciation to the organizer of this event, Dr. Holipah, PhD. Thank you so much for leading your team to create this webinar in hybrid learning mode. We would not have been here in this awesome event without you and the team. In today's webinar, our agenda is to focus on the disseminate of student outbound program. We would talk about the hospital strategy to achieve sustainability and looking towards saving tomorrow resources. I'm sure that today would be full of learning. I hope that this event will help us to grow ourselves professionally. It is all for me. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much to Dr. Tita Haryanti, MKes, for the attracting speech. Hopefully this event will bring advantage to all of us. Ladies and gentlemen, before we proceed to the main agenda, we will pray together and wish that this event brings a lot of advantage to us. To Mr. Zainal Ulu, times is yours.
Bismillahirrahmanirrahim. Let me lead the prayers in the Islamic way. And ladies and gentlemen, please kindly judge in your accordance with your individual conviction. Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Hamdan yu'afi ni'amahu wa yukafi mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalil wajhika wa li azimi sultanik. Subhanaka la nusi sanan 'alaika asna kama asna 'alaika. Falakal hamdu hatta tarda walakal hamdu idza radita walakal hamdu ba'da ridha. Allahumma salli wa sallim ala sayyidina Muhammadin fil awwalin wa salli wa sallim ala sayyidina Muhammadin fil nabiyyin wa salli wa sallim ala sayyidina Muhammadin fil mursalin wa salli wa sallim ala sayyidina Muhammadin fil mala'il a'la ila yaumiddin wa salli wa sallim ala sayyidina Muhammadin hatta tarsal arda wa man 'alaiha wa anta khairul warisin. Allahumma inna nastafizuka wa nastauduka adiyanana wa abdanana wa anfusana wa amwalana wa ahlana wa kulla syai'in a'taitana. Allahumma ja'alna wa iyyahum fi kanafika wa amanika wa iyadika wa jiwarika min kulli syaitanin marid wa jabbarin anid wa zi'anin wa zibagin wa min syarri kulli dhi sar'in kala kulli syai'in qadir. Allahumma hitna bittaqwa wal istiqamah wa a'izna min mujibatin nadamah fil hal wal mal innaka sami'ud du'a. Wa sallallahu bi jamalika wa jalalika ala sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in. Ya Allah, ya Tuhan kami, segala puji untuk-Mu, pemelihara alam semesta. Segala puji atas karunia dan kenikmatan yang Engkau limpahkan kepada kami, ya Allah. Segala puji atas keagungan-Mu, segala puji atas kemuliaan-Mu dan kekuasaan-Mu. Hari ini kami berkumpul di sini dalam kegiatan seminar, berdiskusi mengurai fikir untuk memberikan sumbangsih terbaik bagi bangsa ini, ya Allah. Karenanya, ya Allah, lancarkanlah acara kami, berkahilah, penuhilah pertemuan ini dengan kebaikan dari awal hingga akhir nanti. Ya Allah, bukalah pikiran kami, lenturkanlah lidah kami. Ya Allah yang maha mengetahui yang gaib, bimbinglah kami dengan hidayah-Mu. Berkahilah kami selalu dengan takdir-Mu, dan jadikanlah hati kami selalu ridho dengan pemberian-Mu. Ya Allah, tunjukkanlah kepada kami bahwa yang benar adalah benar, dan berikan kepada kami kekuatan dan kemampuan untuk menjalankannya. Serta tunjukkanlah bahwa yang salah adalah salah, dan berikanlah kami kekuatan dan kemampuan untuk meninggalkannya. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin.
Thank you very much to Mr. Zainal Ulu. Now, before we start the presentation, we would like to take pictures. Ladies and gentlemen, please be willing to turn on the camera. We will take pictures now. To Bapak Ambai, please lead the photo session.
Okay. Open cam. Page 1, 1, 2, 3. Okay. Page 2. 1, 2, 3. Page 3. 1, 2, 3. Okay. Finish.
Thank you, Bapak Ambai. Ladies and gentlemen and distinguished participants, now we come to the main agenda, which is presentation. The first session will be led by Ibu Nurlaili Agustina as the moderator. To Ibu Nurlaili Agustina, time is yours.
Thank you, Ibu Samrina. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. First of all, I would like to thank the organizers of this meeting for inviting me as moderator here today. Welcome to Roadshow and Result Dissemination Student Outbound Program 2022. Ladies and gentlemen, I am Nurlaili Agustina, the first moderator of today's seminar. I am very happy to see you here and welcome all of you to this seminar. The presentation today is about hospital strategy to achieve sustainability, looking towards saving tomorrow resources, learning for Tentine Hospital Thailand and National Taiwan University Hospital. They're all participants of this seminar. Now, in the first session, we will have 3 presenters. They are Dr. Ivit Bagus Afriantono to present Healthcare Policies and Regulations, its role and impact on the quality and sustainability. Dr. Sylvie Rahmayanti to present Caring and Sustaining, Understanding the Impact of Sustainability on Quality of Care. The last one is Ibu Sakina Anura, pharmacist, to present Saving the Earth, Saving the Cost to Financial Impact of Hospital Sustainability. After presentation time, we will have discussion with 3 panelists. They are Dr. Kohar Hari Santoso, Anesthesiologist Consultant, Dr. Vera Wardani, MKes Fiskor, and Dr. Andes Ali Jamhuri Aka, MCom PhD. Opinion, questions, and answer sessions will be conducted after the discussions. If you have any questions, you can ask and write in the chat. It is allowed if you want to ask the question in Indonesian. Well, ladies and gentlemen, let's welcome Dr. Ivit Bagus Afriantono as the first presenter that will deliver healthcare policies and regulation, its role and impact on quality and sustainability. Your time is 15 minutes. Time and screen are yours.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. I am Ivit Bagus Apriantono from Group 1. I am a student in Magister of Hospital Management, University of Brawijaya. Okay, today my team and I will deliver about the presentation. Okay, maybe the slideshow. Okay, thank you. Today, my team and I will deliver about the presentation, and the title is Health Coverage Regulation. This is a study comparative between Thailand, Taiwan, and Indonesia. Next. I'm sorry. I'm very nervous today. Okay, it's okay. Show must go on. Okay. This is what I am going to explain from introduction, method, result, and conclusions. Okay, let me start from universal health coverage. Okay, let's see in the picture. So this is universal health coverage. There are so many questions among people about universal health coverage. There is a question, can I afford it? Are the policies? Can I get a better medicine? Can I get some blah, 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 etc. So to answer the question from the people about the universal health coverage, we have to know about the definition about the universal health coverage. Universal health coverage is a healthcare system. What kind of healthcare system? Universal health coverage is a healthcare system to get access to quality health services from promotive, preventive, curative, and rehabilitative in health services. Of course, quality health services with a affordable cost. Okay, next. Okay, thank you. I'm sorry, this is a little trouble. Okay, let's see in the picture in the slide related to healthcare system. I want to invite you to see these features. From these features, we can see Taiwan reaches the highest rank in the of healthcare system, which means Taiwan has been successful to implement the best healthcare system in the world with the NHI. NHI means National Health Insurance. Okay, we move to the next place. We have a Thailand. Thailand has a number 6 in the world in the healthcare system with the UCS, Universal Coverage Schemes. Okay, from the Taiwan to Thailand, we move to our beloved country, Indonesia. Indonesia has a number 52 in the world about the healthcare system. So, Indonesia has a JKN, Jaminan Kesehatan Nasional. There is still have a problem and need adjustment. So, that's why we can learn from the successor from Taiwan, from Thailand to learn from there to implement the healthcare system Indonesia in the right procedure. I mean this. Okay, now I would like to describe the method of the study. To analyze the data, we implement the descriptive study. We got the data from the joint expert lecture by Flinders University and Brawijaya University, and online hospital visit by Teptarin Hospital and National Taiwan University Hospital of Taiwan. This is our primary data. Our secondary data is use a literature study. Okay, let's move to our first country to discuss is Thailand. As we can see in the picture, there have been several stages that Thailand have passed until today. From the lay the foundation is from stage 1. You can see lay the foundation in 2002. Thailand has laying the foundation to ensure healthcare access for all in the Thailand. And in the 2008, Thailand has developed UCS system. And the stage 3 in the 2013, this is Thailand has move forward for an efficiency system. And now from the 2018 until 2022, this is Thailand in the stage 4. That means Thailand has integrating technology in and connect to the world. Okay, let's move to the right picture. From the picture, we can know about a classification type population in health security schemes. The most is UCS, Universal Coverage Schemes. From all population in Thailand, there are 66 millions. The most is Universal Coverage Schemes or UCS. The next is CSMBS, Civil Servant Medical Benefit Schemes. And the last is Social Security Schemes. So the rest is another schemes. Okay, we talked about the financing. The financing mechanism in this universal coverage scheme is just a capitation. Capitation use a tiered referral service system from PCU to district hospital. PCU, it means primary care unit. Okay, next. Okay, we move deeper from Thailand to Teptarin Hospital. We have done the online hospital visit in the Teptarin Hospital. As we know, Teptarin Hospital located in Bangkok, founded by Prof. Tet in 1985. Teptarin Hospital is endocrinology service hospital, especially in diabetes. And Teptarin Hospital has setting up lifestyle building, health solution club, and weight management clinic. This is like a whole body treatment from preventive until rehabilitative. Okay, we talk about the income of Teptarin Hospital. Teptarin Hospital has several sources, such as from a treatment and all facilities, out of pocket by a patient, private insurance. There is no government health insurance, but still have a reimbursement for a special case, such as a cardiac case, COVID-19 case, accident case, and etc. There is still a reimbursement to government. And the market segment of Teptarin Hospital is a middle to up. Teptarin Hospital is a different from the other private hospital. What uh, why I say different? Because Teptarin becomes a training center in diabetic care and appointed by the World Diabetic Foundation. This is the one and only private with special services in Thailand. Okay. Okay, from Thailand, let's move to Taiwan. From Sawadee we move to Ni Hao. Okay. Taiwan has the NHI, National Health Insurance. National Health Insurance, this is like a UCS in Thailand, Universal Coverage Scheme, but the name is different. NHI, National Health Insurance. Start from 1995. This is a social health insurance that compulsory program for all citizens from birth. And NHI, this has a integrated circuit card. This is like a one card that integrating with all system around them. Okay, NHI use a second generation of NHI system. Okay, uh, where's the income from NHI? NHI have an income from several sources like a participant contribution, the fines due to late payment, income tax, cigarette taxes, and government subsidy. There are four elements that NHI covers in medical aspects, such as the package cover inpatient and outpatient, this is use a Western medication, I'm sorry. The package, there are four elements that NHI covers in medical aspect, such as the package covers inpatient and outpatient, use of Western medication, emergency care, dental services, and traditional Chinese medicine. This is a very special coverage, use a traditional Chinese medicine. Maybe it's the local wisdom of Taiwan that used to be covered in their health insurance, national health insurance. So we move to the next table. The coverage is divided to 6 categories. From the category 1, from the civil servant, volunteer serviceman, public office holder, and etc. until the category 6. Category 6 is like veterans and other individuals. They are all 99% is covered by NHI. Okay, we move deeper in Taiwan. We learn to National Taiwan University Hospital, NTUH. The result of the observation to NTUH, there are several branch of NTUH, like Behu NTUH, Yunlin NTUH, and etc. NTUH built since 1985 in the Tataojeng. Number of staff almost 2,000, number of bed almost 1,000, and the patient who have a services in NTUH is almost 2,000 a day, 2,000 person a day. And NTUH have a mission. NTUH have a vision. The vision is to become the most trusted university hospital, and the mission is to be the guardian of the health from central Taiwan. Next, I will discuss about the income about to NTUH hospital. NTUH hospital, the income is 99% use NHI because the Taiwan citizen or Taiwan peoples, they're all almost 100% all the case covered by NHI, and the rest is use out of pocket and private insurance. We can see in the picture the organization of health system in Taiwan is from the Ministry of Health and Welfare. The ministry just make a policy and regulation, and then administrator by NHIA, National Health Insurance Administration. Okay. Okay, let's discuss the table between Thailand, Taiwan, and Indonesia. This is a comparison between Thailand, Taiwan, Indonesia. The name from the name of healthcare. Thailand use the name is Universal Coverage Scheme or UCS. This is have reached the UHAC. We can see the difference. UCS is the name, Universal Coverage Scheme, but the USC is Universal Health Coverage. This is almost 70% Thailand use these schemes. Okay, and the Taiwan. We move to Taiwan. Taiwan has national health insurance. This is reaches the highest level 2. This is 99% to cover their citizen. And move to Indonesia, JKN is going to universal health coverage. And the regulation in Thailand, Thailand used the Sanitarium Act 1998, Taiwan used National Health Insurance Act, and the Indonesia, the sum of law number that we use in universal coverage system. And the supervisor in Thailand, Taiwan, and Indonesia, this supervised by Ministry of Health. But maybe this is same thing with Taiwan and Indonesia, but almost different with Thailand. Taiwan and Indonesia supervision by Ministry of Health. That Ministry of Health make a regulation, make a policy, but the administrator below them in the Indonesia going to BPJS. But the Taiwan use NHIA. For the referral system, maybe Thailand and Indonesia has the same. There is a referral system. And the financing, Thailand use a DRG, diagnosis related group with global budget and some of capitation. Taiwan use a global budget fee for service and sometimes fee for performance. Indonesia use a capitation with INASI. And the capitation, maybe Thailand and Indonesia has the same. There are primary care unit that can have 5,000 until 10,000 population in this primary care unit. Okay, the things that need to be implemented in Indonesia. We can learn from the Thailand. Thailand has qualified human resources are involved in the region. Thailand has increasing the number of the doctors in this area. Thailand has a developing infrastructure in the region. And move to Taiwan, we can learn Taiwan. All hospitals in Taiwan have implemented the NHI program, market-driven model, and there's no referral system. So there's no cluster for the healthcare services in Taiwan. Taiwan has a low cost but high coverage rate. Low cost but have a high quality in the health services. And Taiwan has administrative technology that's so very advanced. Okay, we move to the conclusions. The conclusion from the three countries. The health system in each country varies greatly but has the same goal. The same goal is to increase the level of public health as high as possible. Each country has its own advantage and disadvantage of each system applied. And the last is every government tries to be able to cover the health insurance for its people. Okay, before I finish my presentation, there is quotes from Carol Bellamy. She said, learn all you can about people in the other of the world, understanding how people in other countries live, work, and play. It teaches us to respect them and promote a peace everywhere. And don't forget, let's join us in MMRS. Okay, I think that's all. Thank you for your attention. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Thank you for your presentation. Next, tune in for the second speaker, Dr. Sylvie Rahmayanti, as the second presenter that will deliver caring and sustaining, understanding the impact of sustainability on quality of care. Your time is 15 minutes. The screen is yours.
Is my voice clearly here? Okay, thank you. Thank you for the screen and the time, Ms. Miley. First of all, to the Honorable Dr. Wisnu Barlianto, Specialist and Consultant, to the respectable Dr. Tita Haryanti, MKes, to the Honorable panelists, and the last but not least, to the distinguished participant and beloved friend. Assalamualaikum warahmatullahi wabarakatuh. Okay, is it clear, my voice? Okay, thank you. I'm hands-free now. Okay, slide, please. First slide. Good morning. It is an honor to have the opportunity to present our paper as the result of hospital visit project that we conducted last 2 weeks. Hospital visits are virtually observing the condition and situation of the hospital to capture the services, the processes, and the systems of each hospital. The paper that we will present is about caring and sustaining the impact of sustainability on quality of care. Okay, let me introduce myself. I'm Sylvie, and this is two angels in me in this room. There are Miss Sabrina, Mrs. And Mrs. Umi. And beside us here, there are two our team behind the screen. Those are Mr. Chatur and Mr. Juan. Give applause, please. Thank you. Thank you. Yeah, I see so tense today. As we knew that hospitals are required to be able to improve the quality of services and set strategy to maintain hospital sustainability. That's why we have to figure it out. What is the importance of sustainability of healthcare service? And then services that maintain sustainability will automatically maintain the quality of hospital services, including patient-centered care, are known PCC. So we need to observe the implementation of patient-centered care in hospital. Then we can get take-home message, and hopefully we do the part of the survival hospital in this disruptive area. Okay, this is why my next script aims to understand the impact of implementing sustainability in hospital on the quality of hospital services, especially in terms of patient-centered care by comparing the effort made by Teptarin Hospital, Thailand, and National Taiwan University, Taiwan. What are the real action of PCC, and then how it's sustainable on those two hospitals. So we just, what action that we need to go. So I will describe the presentation into 4 focus content. Those are the observation of Teptarin, the observation of National Taiwan University Hospital, and our discussion. And the last is the conclusion that we can take and adopt for being a better manager. Let's see Teptarin Hospital. As we knew, it is a private hospital in Thailand. We observe that Teptarin focus on their services. Sorry. This slide in 6th slide. Yes, thank you. This hospital is, they have 3 important points that we can learn. Integrated, guest manager, and one-stop service. Teptarin focus on their services. They have 3 points there. And why it is integrated? Because Teptarin see one focus thing in a priority, then break down into integrated program, which is all of the program answer the necessary of endocrinology. That's why they claim their hospital as endocrinology pioneer. They show us their growth on their focus. They innovate several programs year after year. For the example, the recently program is Smile Silver Society that concern about healthy lifestyle for 16 years old. What is one services? Also show us how you serve in a focused way. It's look like one-stop service. You buy one, get all. That's it. You ask about diabetes mellitus, but you get a million program. The whole program. Those are diabetes center. This is the main focus. But when you get in diabetes center, you get nutrition and dietetic, you got food clinic, and you joining the sports center there, and you get the early screening from ICAT Cardiology Metabology Center. And the most interesting is they have education and promotive services lifestyle in their latter area. They called diabetes escape. Meanwhile, there is so much interesting for us about the case manager. Let me see. They told their patient with this. If you have any question or concern before the appointment. You can contact our hospital anytime. So we're the hospital in Indonesia that you get the sentences anytime. So the most interesting for the whole presentations of adaptarans is their case manager. We can imagine that case manager have a duty to approach each patient individually and seek the problem of their client very intimate. We learn a lot about patient-centered care here. Jump from the Thailand to the Taiwan. Ni hao. Is it right? Sorry. Then we go to Taiwan. National Taiwan University Hospital is a government and hospital teaching and established since 127 years ago. It's old hospital. So this is hospital has three big moves. Is it digital? It is digital health program, contribute to SDGs, Sustainable Development Global, and implementation of patient-centered care also. They claim their hospital serve with premium care, which is provide a healthy workplace environment, take a part of social responsibilities, and commit to sustainable development by encouraging to researchers, medical innovation, learning, leadership, and management skills. That's why this picture show us that they have awards about sustainability. They concern about a more globally sustainability. They choose every SDGs global as their way to focus. And then the innovation of telemedicine and telewound is very, very interesting for us. Next. I told you about premium care in the slide. So they care premium care because they have an ideal standard on their services. Is it researches? Is it technology? Or is it the social contribution? Or is it the care itself? Namely, Twin Star Medical Resourcing Sharing Plan and Yulin Smart Telewound Care High Risk Neonatal Teleretrieval Crowdsourcing Cool Children Heart Screening, Wound Healing Angel. This is the telemedicine power. Houston Apollo Project. This is the telemedicine also, but it's in rural area. Hospice care at home, also like Houston Apollo Project. And the most interesting is about a board of their medical team in Africa. They serve another country. So National Taiwan University Hospital teach us to think globally, to action about no limitation. So we can get that the quality of hospital services is closely related to the implementation of PCC, namely services that control the quality of services for doctors, nurses, overall administrative services, environmental atmosphere, technical services, condition and cleanliness, and that it will have an effect on patient loyalty. This is the goals. First, from this statement from Chahal, 2008, we can capture it from this slide. The PCC lead to sustainability. The PCC lead to sustainability by doing a quality service in the whole process. Is it regulation to the action? Is it the case manager to the integrated program that's shown by Teptarin Hospital, to the innovation that no limitation from the National Taiwan University Hospital. So the sustainable will come itself due to the satisfaction and patient loyalty. Now, how about Indonesia, our beloved country? Actually, this is a rhetorical question for all of us. As we know, the PCC have already set in the accreditation of cars, and it designed integrated on several standard and self-assessments. But there are several obstacles in the implementation, especially human resources. So let's set the action and do the commitment. We have conclusion here, 3 conclusions that we can get take home message for our being better manager. Sustainability is supported by the quality of patient-oriented service. A patient-oriented services is equal strategy in a good and sustainable manner. And the goals of humanity is increased community health status. Finally, we want to show you how caring is about, and sustainability will come itself.
That's okay.
She's in palliative care for it. Today we're called to the facility. Got some IV access going.
There's nothing left to say. There's just a perfect day for us to use. There's nothing else to see. No better place to be. Now that you're here with me, and I'm with you. Why don't we wait here? I just wanna stay here.
I saw a patient this morning with that name.
Why don't we
Is the pain
wait
starting to subside?
here? Now.
Bed management, Michelle speaking. Okay. What's the patient's name? McIntyre? All right, that's a compassionate bed. Let me see what I can do.
You guys need help? Follow this hallway down there and follow the signs to Robbinsfield.
So please don't move an inch. Don't ever change a thing. Just let me take this in and hold it tight. Why don't we wait here now? You can go sleep.
We grew up together,
Why don't we wait?
and we'll die together.
I just wanna stay here. Why don't we wait here now?
Just do the caring, then God will do the rest for the sustainability. Thank you.
Thank you for your great presentation. Next, tune in for the third speaker, Ibu Sakina Anura, pharmacist, as the third presenter that will deliver saving the cost of financial impact of hospital sustainability. Your time is 15 minutes. The screen is yours. Oke, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Sawadee krap, ni hao ma. Selamat pagi, Bapak dan Ibu sekalian. I hope you all in a good condition today. Before we start the presentation, I would like to introduce myself. My name is Sakina Anura, and today I represent my group 5, namely Mrs. Jihan Arabikum, Mrs. Rahmawati Aminingrum, Mr. Zainal Ulu, and also Mr. Dwi Wahyudi. In this good occasion, we would like to presenting our study with the title Saving the Earth, Saving the Cost, the Financial Impact of Hospital Sustainability. As a result of our hospital visit held virtually at 9 March 2022 in 2 different hospitals and also in 2 different countries. The first one is Tataran Hospital, placed in Thailand, and the second hospital is National Taiwan University Hospital, or we can call it NTUH, placed in Taiwan. This is our team. Okay. Basically, to manage hospital sustainability, there is 3 basic principles that the hospital can do. The first principle is by reduce demand of health services. The second principle is by matching supply of health services to demand. And the third principle is by reduce emission for supply of health services. The hospital sustainability itself can impact on certain aspects such as patient health outcome, population health outcome, environmental impact, social impact, and also financial impact. But for today, we only discuss on financial impact. So the objective of our study is to know the impact of hospital sustainability to financial aspect in 2 different countries, Thailand and Taiwan, and we're gonna compare it to most of Indonesian hospital. The method of our study, as I mentioned before, is descriptive study, and we get the data from 2 hospitals, Tataran Hospital and also NTUH Yunlin branch. From the study, we have 2 types of data. The first is primary data, where we get it from observation, interview, and also the presentation of the hospital itself. And the second one is secondary data source, where we get it from hospital website, leaflet, brochure, and any kind of related journal review. So, to do the 3 basic principles, as I mentioned before, there is certain programs that the hospital can do. For example, for the first principle, reduce demand of health services, the hospital can do health promotion, disease prevention, and also chronic disease management. For the second principle, match supply of health services to demand, hospital can optimize primary and community care service, ensure appropriateness of care, and also doing stewardship program. And for the third principle, reduce emission for supply of health services, the hospital can build a green infrastructure, coordinate care delivery, have an integrated technology system, and also do a virtual care. if we analyze all the principle that I mentioned before, Taiwan, Thailand, and also Indonesia have done it. But for the third principle, especially green infrastructure and virtual care, not all hospital in Indonesia have already done it yet. Some of it already done it, but some of it have limitation to doing it. The first principle, reduce demand of health services. This is the basic 3 program that the hospital can do. The first program, health promotion. In Teptarin, they have a link to do a screening diabetes. So everyone can access this link and do a self-check. And for the NTUH, they have a twin star program. For the second program, disease prevention in Teptarin, they have a lifestyle club. And for NTUH, they already done a telemedicine program. And for the third program, chronic disease management in Teptarin, they also have a lifestyle club, as I mentioned before. And for NTUH, they have a long-term care. All of these 3 programs can prevent long-term complication and also reduce cost of universal health coverage. We go to the second principle, match supply of health services to demand. Also, they have also 3 programs. The first is primary of community care service. In Teptarin Hospital, they have MEDE Health Solution Club. And in NTUH, they have a Houston Apollo project. For the second program, ensure appropriateness of care. In Teptarin Hospital, they ensure all patients get continuous care. And for the NTUH, they already done telemedicine and also holistic healthcare project. For the third program, stewardship program, both of countries already doing the stewardship program to avoid the antimicrobial resistance. In Thailand, they doing it with One Health approach. In Taiwan, they doing it with inspection and national health insurance payment system. And the last principle, reduce emission for supply of health services. There are 4 programs that the hospital can do. The first is green infrastructure, can be done by reduce the use of natural resources consumption. In Teptarin, they optimize the use of stair for patient and staff. And in the UH, they have a green land and also roof garden. The second program, coordinate care delivery, can be done by reduce potential gaps between intra and inter hospital. In Teptarin Hospital, the coordination intra hospital was already optimal, and also in NTUH. But for NTUH, they also have a coordination pre-hospital service before referral. The third program, integrated technology system, can be done by having a data integration, reduce the use of physical data such as medical report, printed medical report, and also reduce the maintenance of software costs. In Teptarin, they have a holistic care of endocrinology patient, and in the UH, they have integrated information and technology inter-hospital. And the last program, virtual care, can be done by reduce the operational costs. In Teptarin and also in the UH, they optimize the use of telemedicine. But for NTUH, the telemedicine, including the telewound and telereferral. This is an example. About scenario that the hospital can do to have this is a table of scenario that the hospital can done to use eco-friendly product. So if they want to build a green hospital, they can use LED lighting, window glass, and also day lighting. If the hospital using that eco-friendly that eco material, they can save energy up to 120.94 kilowatt hour. So how to make the hospital sustain? Basically, most of Indonesian hospital have a traditional business model that have a characteristic such as high cost, low quality, and inefficient process. If if Indonesian hospital want to keep the hospital sustained, they need to have a new strategy, new innovation, and also do improvement to make uh, the hospital have a high quality but in low cost and also efficient process. And finally, the conclusion for the first principle, reduce demand of health services. Teptarin Hospital already have screening for diabetes mellitus disease and only focus on out-of-pocket patient. In NTUH, the universal health coverage already done 101.5%. NTUH also have a START program and also integrated referral with telemedicine. And in most of hospital in Indonesia, the universal health coverage only cover 95%, but they have a SISRUT and Prolanis program. For SISRUT is Sistem Rujukan Terpadu and Prolanis is Program Penatalaksanaan Penyakit Kronis. For the second principle, match supply of health services to demand. In Tatarin Hospital, they have MEDE Health Solution Club. For NTUH, they have two programs. The first program is Houston Apollo Project, and the second one is Holistic Healthcare Project for Rare Disease. And for most hospital in Indonesia, they already have a promotive and preventive program by primary care and also a stratified referral. And the last principle, reduce emission for supply of health services. In Teptarin Hospital, they have a good circular supply chain management. They also have a management information system linked with their website and also doing a telehealth. For NTUH, they have a management information system linked with their website and telehealth, just like Teptarin. And they have hospice care at home and also high-risk neonates tele-retrieval. And for most hospital in Indonesia, they already done telehealth. Before we close the presentation, I would like to give our final quotes. Having a healthy mind is just as important as having a healthy body. Thank you so much for all the attention, and we are sorry if there is a lot of mistake in the presentation. Good morning, everyone, and Assalamualaikum warahmatullahi wabarakatuh.
Thank you for all of the presenters. Ladies and gentlemen, the next session is discussion with our panelists. To Dr. Kohar Hari Santoso, anesthesiologist consultant. Your time is 20 minutes. The time is yours. Please welcome Dr. Kohar. Okay, the next panelist. The second panelist, Dr. Vera Lardani, MPhil Viscula. Please welcome. Your time is 20 minutes. The time is yours.
Bapak Ibu sekalian, Sugeng Injan selamat pagi. Kalau bahasa Maduranya apa Pak? Kan udah ada ni hao sama sawadikap ya. Ya, saya boleh bilang goedemorgen juga boleh ya. So first of all, I would like to thanks to all of you because you all are doing your best and I cannot be more proud to all of you. But I can feel that you have a very high tension. That's a feeling very different when the master of ceremony, let's welcome to this seminar. There is no smile, how come? My first emphasis about all the presenter. I enjoy more your presentation than your written manuscript. So on your strategy, if you found that you are being more able to provide presentation first, so you can write on the seconds after you write your presentation, just like for the second group who present. I don't mention the number of the group, but the order of the presentation. Bu Sylvie, your presentation are more complete than your paper. So I did enjoy more your presentation than your paper. And also the third group already gave all the states how to the principle of sustainable development or sustainable practice in the hospital, which is we start with the reduce from the beginning, reduce the need, and then integrate, reduce the demand, and then we reduce the emission. So reduce the emission is the last principle. The first group also have a good start. It's not easy being the first one, isn't it? But if it yeah, it's not easy being the first one. You have to break the ice. Yeah, you have to break the ice, literally. So about what I miss in the presentation is about how we compare the regulation is only on the health financings. If we talk about the quality, we also need to understand the regulation about the quality, which is how the hospital accreditation take a part. So if we compare at least two regulation, we can have more understanding about how this regulation can have more impact on the sustainable development goal. Saya boleh izin share screen ya Pak Dimas ya? Boleh ya? Nggak apa-apa, boleh kok, saya share langsung aja. Just wait a moment. When the second presenter present, Pak Ali give me a very curious question. Which one starting first, the sustainability or the quality? Gitu ya Pak Ali ya. Is it quality bigger than sustainability? Or sustainability bigger than the quality? Does the sustainability will improve quality or the quality will improve sustainability? So I think the group should answer that question, not me. Even he asked me that. This your first title, and after the title you saw how the sustainability will have the impact on the quality, and he directly gave me the question. So you should answer that question after that. So there is, if we talk about the sustainability, most of the people will talk about the environmental sustainability, but there is a growing concept and meaning. If we need to widening and we talk the environmental sustainability, we should talk about the well-being of the customer, the employee, and the community as well. So just answering indirectly to Mr. Ali's question, if we implement the sustainability practice, mean we use the efficient resources management. The third presenter also mentioned all the strategy, how we can use the telemedicine, how we can use the emission strategy. That's part of the efficient resource management. And also the cost effective. If we do perform this efficiency, cost effectiveness, and continuous improvement, mean we forming the service excellency, then actually all the hospital owner will give their more attention to the third part, the business sustainability. It is the ability of a firm to survive over a long time across wide range of phenomena. The COVID told us, how we can survive of all this disaster. And since the third presenters already explained about all the principle, I would like to share this. These are one of the literature review performed to understand what is the sustainability in healthcare. Which one is bigger, Pak Ali? Quality improvement, financial improvement is the goal of the sustainability. So we don't have to put our understanding focusing only on the environmental. Even firstly, when we talk about sustainability, it's about the limited of resources. So we can divide it in the four: environmental, customer, employee, and community-oriented sustainability. All the presenters and the UH is a good example of the environmental-oriented sustainability. While for me, the Teptarin Hospital has more focus on the customer-oriented sustainability. Tadi yang dibilang Ibu Sylvie, TCC is the second part, the customer-oriented sustainability. If we have sustained our customers, mean loyalty, that's also part of the sustainability. It's because we do understand the continuous understanding of customer needs, and then that's why we will reduce the medical bill. Use of health information system is also a good connection between services. There are many proof how use of telemedicine and telehealth is increasing the integrated care and also patient-centered care. Because we have more complete or integrated information, we don't repeat it, all this information. That's also a good part of the customer-oriented sustainability. This, I think, Teptarin Hospital has a good example for this. For me, this interesting. This is private hospital. Do not rely on the BPJS. Private, do not rely on the BPJS, and really only in a specific care. Most people will think this hospital won't survive, but they do survive. Not only just survive, but they do grow. So do not always thinking that we have to follow all the accreditation has to. We have to follow all this BPJS and everything. Find all the small part that we can grow. This small part, if you multiply by the number of Indonesian population, that's a very big opportunity of market. And then employee-oriented sustainability. I think this is not really mentioned, but the Teptarin also give example how they really engage, and also the Taiwan hospital, how they really engage. Because if we also have a problem in the high turnover. So if we enhance the quality of healthcare professional workforce, we have a sustained employee. And don't forget that hospital is part of the community. That's why we need to have some of the project, how we can efficient management on home base. I think the hospice care from the Taiwan hospital, and also interesting, they already perform the not just telemedicine, they also have telereferrals. The examination performed by the rural hospital while the central hospital can, that's really, kalau di Indonesia dulu we have flying doctors gitu, no? Now the doctor doesn't have to fly. Yeah, we can use all this technology. Even we can perform the online surgery using the robotic. That's part of, we are part of the community if we use the health information system, and also how we engage our community, including the family, if they have ability to manage their health. Bapak Ibu can also reduce or increase the golden period of, or the golden time for the referral health system. So I like this because it is expand our understanding from only the environmental oriented sustainability, not just to the environmental, but to the customer, to the people, and also to the community. If you use all these four, meaning the hospital will have a sustainable or long-term. Secondly, based on the first group the first presenter, we also need to understand the country ideology. I think Bapak Ibu, when you give a question to the National Taiwan University Hospital, what is the ideology of this Taiwan? They come of the Chinese hospital, they have a social ideology. saya tidak ingin membangkitkan sejarah, but sociology means communal. So that's why the basic is different with the Thailand who have a monarchy and also us who have a Pancasila, but it is still not clear for me whether it is social or capitalism. Sometimes I found we are capitalist country, even we said we are Pancasilized. And we also have a strong history of monarchy in our country. That's why in Thailand, the role of the king is very strong. But I do understand the King Bhumibol Adulyadej ya kalau nggak salah yang baru meninggal itu, his principle is I don't want my people suffer because they are unable to eat. So their basic principle that this country should be able to fulfill their basic needs. So that's why they have a very strong regulation in the farming. We have a strong regulation on the economy. That's two different things. While in Taiwan, all the answers because of we have insurance, because we have to do this, because the basic country, the basic ideology is socialism. The universal health coverage is the social ideology. I think 2 years ago, 2 tahun lalu ya di Ijen, we invite one from the US, one of the speaker from USA, and then he said that there is no such individualist country who will implement the universal health coverage. Your health is your responsibility, not my business. I don't want to share my salary to other people. So that's why America doesn't have social insurance. Kalau kita masih boleh Bapak Ibu, kita kadang-kadang mengutamakan orang lain ya, walaupun bahasanya masih mikul dhuwur tapi mendem jero, karena itu ada jempolan di belakang sini ya, bendol muri gitu. That's a basic principle. We share but we think gitu. We share but we think, not really sharing. And then how we understand the hospital accreditation as the regulatory tools. There is a different story. Indonesia, I can't say even we said we adopted, but I can say our standards are adopted from TCI. While the Thailand and Taiwan, they have a more long history of developing their own standard. They do have a study of what is best for their country and how they choose the standards. That's two different things. We just directly adopt, while other they develop their own standard, even they still do the benchmarking. That will give different engagement of the standards. That's also the balance between stick and carrot. In Thailand, there is no, even the accreditation is linked to the universal health coverage, but it is also more linked to the quality benefit compared to our country. Bapak Ibu sempat baca sufficient thinking or not dari tanya ya boleh. Thailand, the meaning of Thailand, Thais mean free. So this is the land that never being occupied by other country. But the history of their healthcare, they start with using the universal, the USA as the reference. So they have more specialists than community physician, and they learn if they focus on the specialist or individual care, there is an increasing healthcare problem, there is an increasing cost, and there is no integration, and there is a jeopardize between patient and doctor interaction. Based on that, they start to change the healthcare policy from curative to preventive. That's why they use this as this from moderate to the sufficient. And because they have Buddhism, they follow how the Buddhism philosophy is walk in the middle path. Buddhism never walk in the front and never walk in the back. They always walk in the middle part. Jadi kalau bahasa Indonesia itu so-so aja gitu ya. We don't try to rise as the highest or the best, but just sufficient. sufficient not just for us, but also for the people, because we live also for the future generation. So the philosophy of the country will influence the policy and also influence your hospital. Last, there is also a literature review that told us, it is also surprising me, that all low and middle income countries, actually they don't have the culture of accreditation. It is all transferred from the Western country or from the developed countries. One, use it as the improvement tools. Second, they use as the regulatory tools. Or third, they use as part of the universal health coverage and medical tourism. Or there is some part of coercive transfer, because there is some also international funding who push and support the country to study about the accreditation. So if I have a question, do you think our accreditation policy in our country, which one have a high proportion? It is for the improvement or for regulatory? These two parts. It is more as stick or as a carrot, Bapak Ibu? I asked to the second presenter, and the first presenter. Our accreditation policy, it is more as stick or as a carrot policy. Do you understand what the meaning stick and carrot? Stick is like a punishment. Yes. Carrot is, I don't know why they give the bunny as the illustration, because if you go to the Taman Safari, ke tempatnya Pak Ifit, they always sell carrot, isn't it, Pak? Ya? Oh, bukan ya, Pak Ifit tinggalnya nggak di Taman Safari. I'm so sorry. They always sell carrot, isn't it? They don't allow you to bring sticks. So the carrots, you ask them to come because you give something, not you warn with the punishment or stick. That's why it's not only for bunny, isn't it? Also for llama and also for rusa dan semua deer as well. It's all of you. Pertanyaan dua, Bapak Ibu ya. I don't have my discussion. One, which one is bigger, quality or sustainability, ya Pak ya? Which one comes first? Which one comes first? And then our regulation are more supporting, more act as the stick or as a carrots. I don't want you to answer 50-50. There's no question of, there's no answer of 50-50.
Okay, thank you for the questions. Encourage me. Thank you, all of my friends. In our opinion, from our papers and from the manuscript, is quality first, then sustainability. But when we read about SDGs, as we just overview in our manuscript, those are potential. Then when we take a part of SDGs or Sustainable Development Global Goals, then it will attract us to the more quality of services.
So if we do quality, we will sustain.
Yes.
And then if we implement the sustainability practice, that's also improve our quality of service.
Indeed.
Okay. So we should in one direction. That should be two directions, isn't it?
No, in our manuscript told us that if we action sustainability, so you act like in a quality action, in a quality way, because it's a good and a manner way. But if you have a quality care, so you get the sustainability in a
organization.
Yes,
In the long term survive.
Yeah.
I think because the title is asking the question first, yeah, and then the conclusion is said differently. Your title start with in one direction and your conclusion start in two directions. So I answer this question.
Yeah.
It's good.
And then the second questions about the stick and carrot. I think for my hospital is it cared because the cards always told us that we not do the punishment, but in our action we do afraid of the stick. Thank you.
If the accreditation is not compulsory, Bapak Ibu, will you do or not?
Unfortunately, maybe not. I'm sorry.
So yeah, that's the basic intention, whether we use the accreditation only as the administrative requirement because there is a regulation or requirement, or because we do understand that is, or because I think it's the different case. One, we start because this is requirement, and then second, we learn. There is a benefit of quality improvement. It's different when you start with I want it because it is good for me. So we will not have a 3 years afraid cycle, 3 years afraid cycle, but every year join us of doing quality improvement for us and go to hell what other people said, as long as I do good for me and for my patient. That's the basic thing. So that's why now there is a shifting paradigm from the accreditation. We call it the accreditation 2.0. This is still not 3 or 4.0 because there is 2 tickets only. We have to change that our accreditation is not a checklist, but it's how to encourage and how to discuss. But many people believe because we have a paternalistic culture, so that's why we choose a top-down, we choose the upside pyramid. So we start with the menakut-nakuti ya Bapak Ibu, we start to stick and make people and hope people will understand the benefit. Other will choose, we don't give a stick, but we told you if you do the good thing, you will get this benefit and you have more advantage. So there is no punishment, but you will get more bonus because you do a good thing. That's 2 different paradigms. So thank you everyone, to all of you for this training, for joining with us and for this fruitful discussion. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Fira. Thank you for your feedback. And the next panelist to Dr. Kohar Harisantoso, anesthesiology consultant. Your time is 20 minutes. The time is yours. Please welcome Dr. Kohar.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Mr. Ceremony, Mrs. Moderator, maybe, and also all the presenter. But I want to speak in English, but I'm not sure all of you can understand my broken English. Because of that, I think it's better to me to say in bahasa Indonesia. My apologies. Yang pertama tentang tadi untuk UHC, mohon juga teman-teman ini bisa memahami sebenarnya apa sih masalahnya UHC di Indonesia. Sebenarnya semangatnya sudah jelas bahwa semua masyarakat, penduduk, orang yang berada di wilayah Indonesia, kalau sakit itu harus ada dukungan pembiayaannya. Maka kemudian seluruhnya harus tercover untuk menjaga kesehatannya. Namun demikian ada permasalahan, karena kemudian ada masalah tentang bayar premi, ada masalah tentang bagaimana kualitas pelayanan, ada masalah dengan manajemen pengelola dari pembiayaan tersebut. Oleh karenanya kita perlu simak baik-baik satu-satu permasalahan. Yang pertama tentang pembayaran premi, memang mestinya semua penduduk ya bisa bayar, tapi ternyata ada masyarakat penduduk miskin yang tidak bisa bayar, meskipun itu terlalu murah sekalipun. Oleh karena kemudian ada program PBI, pemberian bayaran iuran. Itu pun sebenarnya jumlahnya kalau kita hitung secara teoritis angka sudah memadai. Karena jumlah penduduk yang miskin kurang lebih 10%, uang untuk PBI itu sudah mencapai sekitar 14%. Tapi ternyata ada juga yang datang ke rumah sakit kita, khususnya di Saiful Anwar ini, yang ternyata tidak ada dukungan pembiayanya sama sekali. Apakah dia lengah untuk daftar atau lengah dari pengurus pemerintahannya, desa, RT, RW, kecamatan daftarkan, atau masalah apa. Jadi mohon bisa dicek betul pada laporan penelitiannya, permasalahan dari UHC Indonesia, apakah masalah ability to pay atau willingness to pay masalahnya, sehingga kemudian bisa berlangsung. Kemudian yang kedua tentang sustainability. Sustainability adalah keberlangsungan bahwa kualitas itu akan bisa berlangsung bagus. Kita tahulah banyak rumah sakit, saya sebagai kepala dinas dulu melihat iki kok ngene kok dari rumah sakit, nah, ada seperti itu. Tapi udahlah, biar jalan rumah sakit, tapi kemudian mesti dinilai, menilainya pakai agreditasi. Nah sayangnya kemudian agreditasi itu menjadi tujuan supaya lulus agreditasi dengan semua manuvernya. Padahal sebenarnya ini adalah tools untuk menjaga kualitas, sehingga kemudian menjadi tidak bagus jadinya. Ini kalau dibiarkan seperti ini terus, kalau sampai kemudian dibuka pintu-pintu bahwa pelayanan dari pihak asing, dari luar, pemodal, masuk semua, maka lambat atau cepat semua akan tergusur. Nah itu makanya. Oleh karenanya kita perlu melakukan upaya untuk menjaga kualitas tadi supaya sustain pada kualitas terus semua. Tadi sudah diuraikan bahwa ada masalah sustainability yang menyangkut lingkungan, customer, petugas, juga masyarakat. Tapi yang utama adalah sustainability di bidang finance. Karena kalau enggak ya enggak bisa jalan itu. Diakui tidak diakui, anggaran adalah darah organisasi supaya bisa berjalan berlangsung dengan baik. Saya kira itu komentar saya. Mohon maaf saya soalnya sambil nyambi segala macam, ini webinarnya ada 2. Sehingga tidak fokus mungkin ya. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Toha. And the last panelist is Dr. Andes Ali Jamhuri, ATA, MCOM, PhD. Your time is 20 minutes. The time is here. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the moderator of this seminar. I would like to thank for all of the participants, and specifically thank you for the committee that asked me to be as one of the discussion here. Specifically, I would like to give some attention for Group 5 that the paper has been sent to me. I would like to thank for your good presentation about the comparison between the experience of Thailand, Taiwan, and also Indonesian healthcare, specifically in their effort to reach sustainability. Three principles that you presented in your presentation is so interesting, and I think it is a simple formula how to reach sustainability. And I agree with the simple formulation that easily understood by almost all the audience also me. But when I try to read in deeper reading, there are some phenomena that I should ask you about. For example, it seemed to me that what you presented and the paper seems to be less in what we call it, the presenting what kind of financial impact that you intend to emphasize in your presentation. Whether, for example, it is like a profit, or might be in more a general one like return on asset, or might be like Dr. Fira just said here, that it depends on the social ideology, or might be the the historical background of country. And I would like to make you one important thing in considering about what financial measurement that you should use it. For example, the organizational form, the different in organizational form or legal status of the organization will make different, will make appropriate different in using the financial impact. That should be measured by your group, for example. And the second one, this is the very important one, is about the efficiency itself. You said that you want to look at to the efficiency in care and how to reach the sustainability. But it seemed to me that once again, it less from your discussion about the efficiency in healthcare itself. The third one is about the some statistical number that you provide in your paper and all, and also maybe in presentation. You provide in your paper that in Taiwan, the coverage of health insurance is 101%. So what does it mean? 101% total population is covered. Yeah. In my understanding, the maximum number of percentage of the population is 100. So it might be something in typography, it might be. Okay. The other one is that even though we agree that sustainability, like Dr. Vira presented just now, that the balances between environment, financial, and society is three concepts, including in the concept of sustainability. But what has been presented mostly is about the natural environment consideration. So once again, less in social environment consideration. I think it is important one. I realize, and now I think with Pupira jointly, we are in considering about the case of Brawijaya University Hospital. And when we try to introduce to the social environment of the Brawijaya University Hospital that we want to rebuild some tower, the social environment reacted extremely. And it is the very interesting case that social environment is as important as the environment, the natural environment, like reducing the emission and so on. It is why, in my understanding, that your paper is so emphasizing about the like the reduction in emission level, and I believe that it can be improved substantially when you also give balance attention to other element of the sustainability, like Dr. Vira stated just now about the financial sustainability as well as the social sustainability. I think it's all for me. Thank you.
Okay, thank you, Mr. Ali. I would like to answer the question. The question number one is, our team not just focus on profit, but we are focused on reducing of costs, reducing costing of and efficiency costing. We are we still focus on profit, not abandon the profit, but we are focused on how to reducing costs of financial impact. I think that's all for me. Maybe my friends and
Maybe the group. I think the question is also about, is there any other financial measure of practicing sustainability? You already mentioned about the operational saving cost. Isn't it in your, I think one of your reference mentioned that the hospital could save this if they perform the sustainability strategy. But is there any other measure? If you know other measure, so you can add. So if not, I think this is also a good discussion. Mr. Ali mentioned about the social impact.
Yeah.
I did mention about the sustainability in the employee. We also can measure how much is the cost of every nurse turnover or every employee turnover. That's another cost. Or you have you already did an article who proved that the return on investment is higher for the hospital if they implement sustainability practices. Is there any other measure, not just the cost?
Okay,
operational
for
saving?
the result of our observation into hospital, Teptarin and also NTUH, they only focusing on environment and social impact. So there is no direct impact to a financial aspect. For the environmental, both of the hospital focus on build a green infrastructure, and also like Teptarin Hospital, they optimize the use of stair for patient and also staff, so they can reduce the cost of using lift instead. And for the NTUH, they build a green infrastructure, they have a green land, so they maximum the use of daylight in their building and any other efficiency in environment aspect. For the social impact, both of the hospital in Teptarin and also NTUH, they focus on promoting and preventive program to prevent patient to prevent the patient to fall in a complication condition for their disease. And I want to also answer the question from Mr. Ali about why it 101.5% in NTUH and also in NTUH. In NTUH. So in Taiwan, the government not only cover their people, but they also covered the immigrant. So that was why the universal health coverage covered more than 100%.
We should be in careful situation because even though they are immigrant, their population. So it is impossible to say that in terms of percentage, population is more than 100%. Yeah, the population and the what we call it, the nationality income. For example, I'm Indonesian, and I live in Taiwan, for example. So I'm an immigrant, but the immigrant in the time being is also a population of Taiwan.
Oh.
You know what I mean?
I think you need to add the explanations about the 101. I think this depend on the number they used to divide. If the number they used to divide is only the number of people covered that should be covered, that's understandable. Maybe the immigrant is not should be covered, so that's why more than 100. Just need an explanation. But Pak Ali in one point also right. If we think about the people, so all the people in this island is our population, whether they are legal or not legal.
Yes.
But I think you just need to add the explanation.
Actually, in the journal that we read, they compare 3 countries: Indonesia, Taiwan, and Canada. The same condition with Taiwan. Canada have this. Canada also have the same condition with Taiwan. They have more than 100%.
Okay. So just you just you should add explanation or description like what Dr. Pira said.
So we add the explanation,
Yeah,
temporary
because-
visitor and also
Yeah.
immigrant.
Yeah.
Okay.
Okay.
Okay, thank you.
Okay, I would like to give you one other. Please read the title of your paper. It's very interesting.
Saving the earth, saving the cost, the
Yeah, it's
financial
okay.
impact.
That's very nice. But the subtitle, dampak finansial terhadap keberlanjutan rumah sakit. This is the problem, I think. Yeah. Normally, if you think like in quantitative model of research, the the letter comer here is keberlanjutan rumah sakit is the dependent variable, yeah, and dampak finansial is independent variable, yeah. So this is the like we want to know about whether if hospital have what to call it, the good condition of financial position, for example, then what is the impact into the sustainability of the hospital? Yeah. So I think it will be better for you when you rewording this title in order to make it clearer, and your audience of the paper will easily understand what you want to deliver the message, because it's like something not easily understandable.
So the right title is Hospital Sustainability to Financial Impact.
I don't think so, but by putting the word financial impact, it is like financial impact to hospital sustainability.
I think you just need to change the preposition instead of terhadap, the financial impact of, not terhadap. Is that what you mean? The financial impact of keberlanjutan rumah sakit. Or you better explain what do you mean with the title, and then we can rephrase the title. Sebenarnya maksudnya apa titlenya? Dampak finansial terhadap keberlanjutan. Dampak finansial of what?
Sebenarnya bahasa Indonesia ya Bu. Sebenarnya ini kemarin juga menjadi pertanyaan kami. Sebenarnya yang berdampak dulu itu finansialnya atau hospital sustainability-nya dulu. Kemudian akhirnya kami memutuskan mengapa di awal, di slide kita awal kita bahas dulu bagaimana cara memanage hospital sustainability dengan 3 prinsip, kemudian hospital sustainability itu mempengaruhi aspek mana saja, termasuk salah satunya adalah aspek finansial. Sehingga yang kami maksudkan sebenarnya, yang kami tangkap ya Bu ya, hospital sustainability itu memberikan dampak ke finansial.
So that's why it is off, not terhadap ya. If you want to discuss too, you can discuss the financial impact of sustainability practice and its impact to the sustainable business. If that's what you mean. That's why Mr. Ali asking, but which one is the independent and dependent variable? Which one influence which? This is the sustainability practice influence the financial, and then after that, the financial will influence the hospital sustainability, because there is 2 things. If we talk about the sustainable practice and hospital sustainability, it's 2 different things. Hospital sustainability about the business sustainability. The sustainability practice is all the strategy to implement the sustainable development. So if you ask the impact of the sustainable strategy to financial, and then its contribution to the business sustainability. Is that what you try to explain or not? Which one comes first? That's our first question. The sustainability or the financial impact? Which one comes first? Financial impact of what? No, if we talk about if dua-duanya, you use dan. Dan berarti you only mention all independent variable, there is no dependent variable. Mana mempengaruhi mana wes Bu? Pasnya. Tidak ada. Because you mention dampak yang terhadap, itu berarti there is an independent and dependent variable.
Financial impact-nya. Sustainability ke jadi tahapan dari sustainability-nya ke financial impact. Bisa 2 arah. Kalau menurut logika ya Bu, bisa 2 arah. Jadi yang kita bahas ini adalah strategi sustainability-nya tadi, mulai first principle, second.
Yeah, 2, and its financial impact.
Terhadap financial impact-nya.
Okay, this is 1 direction or 2 direction. Meskipun saya lebih suka group 1 direction instead of 2 direction. It is 1 direction, then you will say the financial impact of sustainability strategy. Tapi kalau keberlanjutan rumah sakit itu beda Bapak Ibu ya, dengan sustainability practice. Sehingga kalau kita bilang the impact of sustainability practice on to financial and its contribution to the hospital sustainability. Nah, that's more yang 2 arah gitu tuh, karena dia punya financial impact sehingga rumah sakitnya bisa berkelanjutan. Betul kah begitu? It is my guessing. Atau saya ganti pakai bahasa Indonesia ya?
Jadi memang dari
Which one?
tahapan yang tadi ada 3 prinsip itu,
Yes, okay.
itu mempengaruhi dari financial impact terhadap keberlanjutan.
Bapak kalau mempengaruhi financial impact jangan dikasih impact lagi, mempengaruhi finansial. Sehingga kata kerjanya adalah kata benarnya financial, impact-nya kata kerjanya ya. Oke. So the impact of sustainability practice on financial or the financial impact of hospital sustainability practice. Is that? Okay. Thank you. Clear Pak Ali. Sudah Pak Ali, enggak nambah, sampun. Ya sudah Bapak Ibu, terus thank you for all your presentation and contribution to this great session. Thank you.
Thank you for the feedback. Well, Ladies and gentlemen, now come to the discussion session. If you have any questions or opinion, you may ask to the presenters. You may raise hand and unmute your microphone and ask directly or write your question in the chat. It is allowed if you want to ask the question in Indonesian. For participants in this room, please stand up and don't forget to mention your name before giving opinion, questions, or answer. Please, participants, who asks next? To group 1,
There is
4,
three
and 5.
participants raising hand.
Okay. Please, Pak Unix.
Thank you. Thank you for the opportunity. I'd like to ask for group 1. In the presentation, there is universal coverage scheme in Thailand that's growth so big and so good. According to your group, what are the factors? I think there is a support system. What are the factors that contributed to development of universal coverage system in Thailand? Thank you.
Please, group 1 to answer. Thank you, Mr. Unix. Thank you for the question. We will try to answer the factor that contributes to the development of universal coverage scheme in Thailand. They are first, a health development system. Thank you for the question. We will try to answer the factor that contribution to the development universal coverage scheme in Thailand. They are first, health development system from regional and provincial health facilities. The second is education strategy by recruiting health worker from remote area. The third is incentive financial, that interesting and various. With all the things I have mentioned before, it is proven that universal coverage scheme in Thailand can run well. Thank you. Thank you. The next question is from Pak Ari. Please stand up and giving your question.
Thank you for the opportunity. I want to ask a question for group 1. Similarly with Mr. Unik, why the universal health coverage in the Taiwan so developed? Even within 27 years, it has covered until 99% Taiwan citizen. Thank you.
Thank you for the question from Pak Rahmat Ari. Because the Taiwan government is very concerned about the quality of medical standard are recognized by the Taiwanese community and internationally. And then health insurance in Taiwan can cover all service costs. Even traditional medicine is borne by national health insurance, and certain items of convenience insurance participant can enter the large hospital or the small clinic, and then at any time and can get medical assistance as soon as possible. And then which does not apply in other country. And the insurance system in Taiwan has used digitalization and cloudization of patient medical record.
How about Pak Ari? It's enough. Okay, thank you. Okay, any else for the next questions for audience? Okay, the next. Okay, the next person. The next person from Budini, please stand up and mention your questions.
Thank you for the time. My name is Dinin Raida. I want to ask to group 1 about advanced technology in Taiwan. Can you explain to me about advanced administrative technology at Taiwan? Thank you.
Please group 1 to answer the question from Budini.
Thank you. I will try to answer the function of administrative technology is for insurance claim process that is can minimize the fraud, both corruption and abuse of the authority of service providers. IT also make it easier to collect data of the patient medical history, so the doctor will be able to treat patient more quickly and avoid misdiagnosis. It is a use card equipped with 2 chips too, that owned by patient and healthy and health service provider are directly connected to NHI administration body. So the patient data and service provider are always updated in a real time. Maybe this is my answer.
Budini, how about the answer from group 1? Enough. Okay, thank you for group 1. The next person can answer to group 4 or 5. Please, all participants. You may raise hand and unmute your microphone and ask directly or write your question in the chat. To moderator, can I add some explanation to Mr. Unik before is that time allowed or not? Pak Unik, I would like to clarify the question whether you ask about whether you are curious because the Mr. Ifit right that the UHC is not 100%, and then you're asking why not 100%. Is that your question? What factors support it? I think Pak Ifit can present. In Thailand, there is already 100%. There's already 100% because they use, it's not because. They use not one scheme. Indonesia only use one umbrella. In Thailand, they use at least more than 3. So before this, let's make, Pak Ifit already explained, let's make us confuse universal health coverage scheme. It's not universal health coverage like our understanding, all the people are covered. Thailand already, like us, they already have several schemes. Like for us, for civil servant yang dulu askes itu ya Pak ya. And then in year 2002, they start to introduce the universal health coverage scheme to cover all the people who aren't covered with other scheme. Actually, they also think to combine all in one, like what Indonesian did. But there is a resistance from all the people who already covered by different insurance scheme, because there is a different benefit of the insurance. The answer is correct because there is a policy, because they have a, at the national level, they have what they call as the triangle. This triangle, one, they have a group research who always continuously measure the impact and also developing the Thai DRG. We have the INA CBG, they have the Thai DRG team. This Thai DRG team are continuously improve the measurement or the calculation of the DRG. As you know, in Indonesia, we never change the INA CBG, isn't it? Since its beginning. So, as far as I remember, they also, one of the innovation is they changed about the multiple organ intervention. If we have injury in one finger or in 2 fingers, they do have a specific, because they know operating in 2 fingers in one time is not equal to operating 1 finger 2 times. So that's why they have a specific DRG for multiple organ intervention. They also start to develop not only acute, but para-acute and also chronic. They have specific for your hospital, for mental health. So because they know it is a long term. So once, because they do the research, evidence-based health practice, and also it is connected with the university and also the country. When I ask the question, how can you come to all the hospital asking their data? Their answer is just simple. I come, I ask, they give. Meaning there is a good connection and collaboration. There is no need to ask permission because they all agree that hospital should provide the data, and there is a team who conduct the research, and this inform to the policy what kind of change they need to implement, and the change is implemented. That's how the evidence-based health practice are performed in Thailand. They're still continuously growing. We have all this university, but there is no connection between knowledge and governments. I think that's one of the problems. Thank you. Thank you, Dr. Fira. Thank you for your additional explanation. Okay, Pak Unix, how about the explanation from Bu Fira? Any questions? Pak Unix, clear. Thank you. The next question from Pak Aryo Dewanto. Please talk.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. I'm Aryo Dewanto. I'm from home. Actually, I'm in MMRS. If you haven't know me. First of all, I'd like to thank you very much for the very interesting and valuable presentation. And I give my highest appreciation for all presenters and the teams for doing the best effort to present in this very challenging time. I am very sure that if you can choose, you will choose to go to Taiwan or to Thailand to see the fact directly rather than doing a online hospital visit. And with all those challenges, you can present very good today. But first, I'd like to suggest only maybe for particularly for Pak Ifit group or other group, when you do a comparison, you could elaborate more about the content rather than presenting the title. Like if you compare about the regulation, you can provide explanation about the regulation. How does they differ? Maybe like that. It's only suggestion when you give another presentation next time maybe. And the second thing is I'd like to have your opinion. How does government support hospital, particularly in terms of human and financial resource to achieve universal health coverage in those two countries, Taiwan and Thailand, compared to Indonesia? Like as we know in Indonesia, the government support mostly in terms of financial, mostly is for prevention, and the support will go to the primary care. And how about the hospital in Indonesia? And how government in Taiwan and Thailand support the hospital there? Okay, thank you very much. Maybe for all group or for first group. Thank you very much.
Okay, thank you, Pak Aryo. The next question is answer. Please, group 1 for Miss Pak Ifit. Please stop.
Okay, thank you for the question, Pak Aryo Dewanto. Okay, this is how the government support hospital in the each country. Maybe for Indonesia and Thailand, this is the almost the same method to universal health coverage in our country or the Thailand. Thailand and Indonesia have almost the same method. Thailand, since 2002, this grew from the several schemes from CSMBS, SSS until the 2002. They reached the universal coverage scheme, the universal coverage system in Thailand. So this is same with Indonesia. Thailand and Indonesia have a referral system in the healthcare system. Thailand has PCU, Indonesia has PCU too, primary care unit that insert the referral system for PCU the hospital. So Indonesia and Thailand have some of district hospital from secondary hospital and tertiary hospital. There some type of hospital that Thailand and Indonesia have in set. From Taiwan, there's a different. Taiwan has a governance as a Ministry of Health to make a regulation and policy. Maybe this from the regulation, Indonesia and Taiwan is the same. Indonesia and Taiwan have a Ministry of Health to make a regulation and policy as a regulator, and then the the administrator below them, below the Ministry of Health. Indonesia have a BPJS. In Taiwan have a NHIA who run the coverage scheme in the country. So this is the method from government to make a hospital sustain and growth in this universal coverage area. And there are there are some different from the Thailand, Taiwan, and Indonesia, whereas Indonesia is pure from the apa ya istilahnya kalau bahasa Indonesia. Jadi BPJS itu ada kayak PBI sama non PBI gitu Pak. Jadi terus kemudian kayak dua skema tapi satu nama yaitu BPJS. Kalau misalnya Taiwan is just a pure NHI. This is come from the government and the income of NHI is from the taxes all the most from the taxes of the country. And Thailand is almost the same. This is use capitation and pay in apa ya istilahnya kayak out of pocket langsung premi bayar dari people di negaranya gitu Pak, sama kayak Indonesia. Sebenarnya dari three country ini hampir mirip tapi beberapa sistem memang agak berbeda gitu Pak. Thank you very much.
Thank you Pak Ifit. Boleh tanya lagi ya? Actually, in more specific question, like if I'm not mistaken, I heard from your presentation that in Thailand, the government secure the number of human resources for health in the area of the service, and actually, what I want to know is whether is there any financial support from government directly to the hospital? Is there any financial flow for government from government to the hospital to achieve the universal health coverage? Thank you.
Okay. Time. Oh, for the financing Pak Aryo ya. Jadi for the financing in Thailand, Taiwan, and Indonesia, maybe Indonesia is will use global budget in this system, because the system until us is we already use still in ACBGs with the capitation maybe with BPJS. And for this is a different from Thailand and Taiwan. From Taiwan is full use a global budget from the government. There is apa ya? Coverage-nya itu memang 100% dari government, tapi sometimes use a fee for service and fee for performance in their country. And the insert of an health insurance, insert the as a apa yang seperti yang di slide itu yang dijamin oleh NHI-nya Taiwan itu dia 6 kategori Pak. Jadi mulai dari kategori 1 itu kayak civil servant itu terjamin. Insertnya apa saja sampai yang di kategori 6 itu kayak veteran sama mungkin ekspatriat itu insertnya bagian apa saja itu berbeda-beda dibedakan. Tapi beda lagi dengan Thailand. Thailand juga sometimes use a DRG diagnosis. Mungkin in Indonesia in SPGs, in Thailand is DRG diagnosis related groups with capitation tuh kayak gitu Pak. Tapi sama apa ya sama-sama gitulah istilahnya Thailand dan Indonesia.
Ya, terima
Maybe
kasih.
if I have mistake, I need the more advice from you Pak Arya. Terima kasih.
Maybe we can discuss another time. Thank you very much Pak Ipit. Salut buat grupnya semua. Terima kasih.
Thank you Pak Aryo. Thank you for group 1. Okay, all participants, any questions? Maybe the last question. Okay. Please stand up, Bu As.
Thank you for the time. My name is Asi. I will ask for group 1. This my ask, how does the with the existence of the 3 health Thailand insurance scheme in Thailand, and with does Thailand apply Thai reference service system? Thank you.
Okay, thank you for your question, Bu Asi. Please group 1 for answer the question from Bu Asi.
Thank you for Bu Asi. Thailand, 99% of the population is protected with 3 schemes. Universal coverage scheme, 75%. Social health insurance for formal private sector, 20%. Civil servant medical benefit scheme, 5%. The implementation of UCS requires of a good financing strategy, so that with the child referral service system, it is expected to eliminate financial constraint on health service. Thank you for Bu Asih.
Okay. The answer from group 1. Clearly, it's enough. Okay, thank you for group 1. Okay, well, all participants, I think it's enough for the discussion session. The conclusion of the first session today's seminar are: 1, the health system in Indonesia, Thailand, and Taiwan varies greatly but has the same goal to increase the level of public health as high as possible. Each country has its own advantage and disadvantage of its system applied. Every government tries to be able to cover health insurance for its people. 2, caring and sustaining, understanding the impact of sustainability on quality of care. The sustainability of health services in hospitals is supported by the quality of patient-oriented services. It is hoped that every hospital will carry out a patient-oriented service quality strategy in a good and sustainable manner, so that an increase in community health status will be achieved. The last, saving the earth, saving the cost. The financial impact of hospital sustainability. We can learn from Peptarin Hospital and National Taiwan University Hospital about reduced demand for health service, met supply of health service to demand, and reduce emission for supply of health service. We would like to say thanks again for the presenters and all of the audience for active participation. Hopefully, the presentation will give benefit for us. Thank you for your attention. Back to you, Ibu Samrina. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Ibu Nurlaili Agustina, for leading the presentation and discussion. It has been very interesting, and I'm sure the feedbacks from the panelists are very useful for our improvements. Ladies and gentlemen, before we continue to second session, we will have 2 hours breaks, and I hope we will be ready in the site at 1 p.m. Thank you very much and enjoy the break time. Excuse me, the attendance link will be given in the second session, so please continue to follow the event until the end. Thank you.
Senso dan Repair and Protect di Protection, membentuk lapisan mineral untuk perlindungan mendalam gigi sensitif.
Okay, okay. Okay.
Ladies and gentlemen, we will start the event in second session in 10 minutes. Please be seated. Ladies and gentlemen, we will start the second session in 5 minutes. Please be seated. Ladies and gentlemen, welcome back to the event. Now we come to the second session, which will be led by Ibu Chandra Novi Darmawan as the moderator. To Ibu Chandra Novi Darmawan, time is yours.
Thank you, Ibu. Thank you, Ibu Sabrina. Good afternoon, ladies and gentlemen. I hope today is your wonderful day and our discussion will be begin. My name is Chandra Novi Darmawan. I will be the moderator in this session. Dear all participants of this seminar, now we will continue the topic from two presenters. They are Mrs. Katarina Luis to present Managing Clinical Governance, Balancing Sustainability and Clinical Governance. And Dr. Rahmat Ari Irmawan, internist, to present Designing the Hospital Building to Sustain. Each presenter will have total of 15 minutes for their presentation. After presentation time, we will have discussion with two panelists. They are Mr. Tito Hari Pradianto, STMT, and Professor Dr. Ahmad Rudianto, internist consultant. Opinion, question, and answer session will be conducted after the discussion. If you have question, you can ask or write in the chat. It is allowed if you want to ask the question in Indonesian. Well, ladies and gentlemen, please welcome Mrs. Katarina Luis as first presenter that will deliver Managing Clinical Governance, Balancing Sustainability and Clinical Governance. Time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome to my presentation. First of all, I will introduce myself. My name is Katarina Luis Rinanti. I am the first year student of Master Hospital Management Study Program, Faculty of Medicine, Universitas Brawijaya. I represent my group to present the result of the hospital visit project that we conduct last week. My team consists of me, myself, Mr. Unik Cahya Husada, Mrs. Asih Setianing Bukti, Mr. Dwi Saputro, and Mrs. Annabella Marquez. The title of my presentation is Managing Clinical Governance for Hospital Sustainability, a study of Teptarin Hospital and National Taiwan University Hospital. I will deliver 6 points in my presentation. They are overview, aim and methods, result of student outbound program, comparison of implementation in Indonesia, conclusion and suggestion. As we know, clinical governance is comprehensive mechanism for ensuring that high standard of clinical are maintained throughout the system and the quality of services is continuously improved. Clinical governance also to bridge the managerial and clinical approach to improve service quality and sustainability to provide health services for all generation, good finance organization, and environment friendly. The aim of hospital visit to describe the implementation of clinical governance for hospital sustainability. To achieve the objective, we conduct literature review, online interview, website, and focus group discussion. Okay, in the next slide, there are 7 pillars of clinical governance. There are clinical effectiveness, clinical audit, risk management, use information, education and training, staff managerial, and patient experience. In Thailand, the clinical governance is very important because has a system throughout the clinical service and create a new healthy lifestyle. Teptarin Hospital focuses on diabetic and has disease-specific accreditation for diabetic. As we seen on paper, all clinical governance processes are supported by reliable and competent human resource because Thailand cares deeply about human resources development. In Taiwan, clinical governance related the people and digital health care services. Each time of the clinical governance will be support the health services with technology. National Taiwan University Hospital owned by government and has 5 branches spread across several regions, and all branches apply the clinical governance to a standard. Clinical governance process in Taiwan are digitally integrated and supported by the healthcare equipment. Integrated of clinical governance in both countries make an impact for hospital sustainability. Teptarin Hospital has a sustained philosophy, which is working in STAR lifestyle and sustainable social enterprise model. The same as Taiwan, which supported digital health, smart medical care, hospice care at home. Those healthcare activities will save energy, reduce pollution and medical waste at hospital. If we compare to our country, Indonesia, the implementation of clinical governance in our country is still a challenge for hospital management and professionals because to realize in real terms, synergy and collaboration need to be able to blend in the internalization of service and organizational culture and hospital. Thailand and digital health in Taiwan shows the existence of sustainable process of services provided by hospitals. Then the use of medical record electronic is still a process carried out in our country, Indonesia. Currently, most still use paper. The use of electronic medical records will be more environmentally friendly. Patient involvement is an interesting thing. Patients in Thailand are closely involved with service providers. Since before the hospital treatment process have been invited to recognize their needs. When intra-hospitals have been provided with various services to prevent disease and change lifestyle, and post-hospitals with still providing better lifestyle health advice. Patient involvement in Taiwan using gadget, which allow unlimited range of health services from distance and time. While the process in Indonesia, patient involvement direct only to intra-hospital process. From the result of studies in Thailand and Taiwan, the implementation of clinical governance that has led to sustainability. The development of sustainable mindset creates service innovation. Then the implementation of clinical audit and risk management has considered risk to the sustainability of services, finance, and environmental factors, which leads to use electronic medical record as well as patient involvement in terms of digital-based health services. There are some obstacles in Indonesia related to research process regarding sustainable services for hospital, which has not been optimal. The application of clinical audit still carry out of the purposes accreditation demand on patient safety. All hospitals may not have same ability, still has minimum standard. The culture is not ready to change. The policies that have limited people's choice and the types of services that can cover the financing. From this hospital visit, we would like to conclude 2 points. Both of the country has the advantages of engaging patient experience, patient need, and providing sustainable services and combination of digital. However, in our country, the implementation of clinical governance is still only based on administration. For hospital accreditation, also still growing to be culture. Last but not least, we would like to suggest that hospital services have to synergy and collaboration of stakeholder, hospital management, and professional to support the changing of organizational culture toward hospital sustainability. Indonesia still have a big homework in 3 aspects to solve, which are healthcare and people mindset, policy support, and research best practice in service. Never give up on what you really want to do. The person with big dream is more powerful than one with all facts. That's all my presentation. Thank you for joining us.
Thank you, Ms. Katarina, for that excellent presentation. Okay, next topic will be presented by Dr. Ahmad Ari Irmawan, internist. As second presentation that will deliver designing the hospital building to sustain. Screen is yours.
Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. It's an honor to have the opportunity to present our paper at the result the hospital visit project that we conducted last week. My name is Rahmat Ari. I am the first year student of the Master of Hospital Management Study Program, Faculty of Medicine, Universitas Brawijaya. I am here with my group. They are Miss Dini, Miss Laili, and Mr. Teddy. In our presentation, we would like to report about the designing the hospital building to sustain. In our presentation, we will focus on 4 major issues. They are introduction, method, result, and conclusion. First, I'd like to give you an overview of introduction. Hospital building and environment are important for the running of health service. Hospital building and environment design affect the patient recovery and safety, and how resources are used effectively and efficiency in the hospital. The characteristic of the physical environment of the hospital facility are designed to prioritize comfort and safety for the patient. And so it is necessary to analyze the possibility of implementing in the practice in Indonesia, the implementation constraint that might arise, and the solution. Secondly, we will focus on the method. To analyze the data, we administer the descriptive study. It used 2 sources of data. Number 1 is a primary data from observation, interview, and research presentation, and secondary data is the obtained from the literature. The data were obtained from the joint lecture lectured virtually at Teptarin Hospital and National Taiwan University Hospital from 4th until 9th of March 2022. I did like you to see this picture. It shows the building of the Teptarin Hospital. Teptarin Hospital is private hospital that focused on endocrinology service, particularly diabetes. This hospital located in Bangkok in the center city. Interestingly, the Teptarin Hospital has the 17th floor that have a purpose to patient healthy lifestyle, like increasing the physical activity. Teptarin Hospital also applies the green hospital concept in infrastructure implementation and decision making. And you see the picture, it shows the National Taiwan University Hospital picture. It's located in the Changdi Street, located in the center of city, and the National Taiwan University Hospital was affiliated with National Taiwan University College of Medicine and provide the complete range specialist and subspecialist service with more than 2,000 beds and in the main hospital and 5 branch hospital across the island. Thirdly, we will focus on result. The country visit explain the importance of the concept of hospital sustainability, and the hospital that we visit do not focus on hospital design, but also focus on the effectiveness of health service. Hospital in Indonesia can implement strategic initiative that have been implemented abroad. Based on the result of observation and hospital visit, interview, and Teptarin Hospital, there are several things that can be adopted in Indonesia. What can be adopted from Teptarin Hospital is the principle of healthy building and environment friendly. Although the preventive concept that Teptarin Hospital is very good concept, in practice in Indonesia maybe it can be difficult to apply it in Indonesia because there are still many Indonesians who don't have awareness to live a healthy life and no regulation on government policy that regulate the citizen to better implement healthy living. And then we will focus on gap between Indonesia, Taiwan, and Thailand. Indonesia have a regulation of the Minister of Health Republic Indonesia and number 24 and 2016 about the technical recommendation for hospital building infrastructure, and update in 2021 about the business activity like a feasible study, master plan, and documentation. In Indonesia, technical recommend hospital building and infrastructure must meet service standard, security, and occupational safety and for hospital administration. And The technical requirement the building include aspect of building layout and building reliability. And so, and thing on consider to building plan, zoning, building mesh, and wall, door, toilet planning must follow the building and environment planning plan. And another problem that there is communication gap between the hospital manager and implementer in the fleet. And in Taiwan, with more than 2,000 bed in the main and 5 brand hospital across the island. And the Thailand, which is a healthy building, is lifestyle building and 80 bed capacity located in 11-story building. And finally, we would like to address the conclusion with the approach of the hospital sustainability initiative aspect of hospital design in the both hospital. Namely, the design of building and the hospital environment that has an impact on the use of resource in the hospital. Before we close our presentation, we like to give one final quote. The hospital is worth 1,000 words. I think that's all our presentation. Thank you for all the attention, and we are sorry if there is a lot mistake in this presentation. Thank you. Goodbye everyone. Assalamualaikum warahmatullahi wabarakatuh.
You for that excellent presentation. Okay, ladies and gentlemen, the next session is discussion with our panelists. To Professor Dr. Ahmad Rudianto, Specialist Internist, your time is 20 minutes and the time is yours.
Before giving the comment.
Okay. Okay. Okay, the session will.
No, because actually when I give you suggestion, I must know well according to the from the audience and give you more complete comment.
Maybe from the audience, if you have a question or opinion for group Mrs. Katarina, you can ask the question. Okay, you can raise your hand, or in the home, you can unmute your microphone and ask directly, or write the question in the chat.
Check.
Okay.
Thank you for the. My name is Umi Kulsum. I want to ask for second group about what are the goals of healthy building applied in the Septarin Hospital.
Okay, maybe another question again. I will open with 3 questions first.
Thank you. My name is Kitchen Ulfina. I will ask to group 3. How is the Septarin Hospital applies risk management principle? Thank you.
Okay, one question again.
Thank you. I want to ask to group 3. The case manager in Indonesia is not as optimal as in Septarin. What is your group opinion about the barriers to case manager in Indonesia?
Okay, for the question in the daring, can in the next session. Okay, for question in this session, presenter on the group.
Aku boleh tanya,
Oh yes.
boleh tanya aku.
Okay. For Pak Ali Imam, the question please.
Ya, bahasa Indonesia ya. Yang untuk soal building, hospital building ya. Indonesia kan ring of fire ya. Bagaimana di Thailand ataupun di Taiwan sehubungan dengan kebencanaan? Terima kasih.
Okay, we have 4 questions, and I hope the group can answer the question.
Thank you. I try to answer the question from Miss Umi. Taptarin Hospital is designed in such a way to achieve treatment against diabetes mellitus holistically. This includes clinic diabetes, laboratory, food care, eye care, place for food education, gym, and swimming pool. The health infrastructure facilities at Taptarin Hospital not only have an impact on improving health and welfare of the Thai people, but also has an impact on improvement of public education in terms of the sustainability. Thank you.
Okay, maybe the group will answer the next question.
Thank you for question about Miss Cicin about risk management. Yeah. Risk management in Taptarin. Also is this example is complaint. Complaint will be divided into several level of risk. For low risk level, supervisor can take the complaint and solve immediately. For higher risk level, matter will be reported to manager and higher management. Yes.
Thank you, Mr. Dwi. I will add about risk management and also answer the risk management from for Ms. Cicin. In Taptarin Hospital, risk management also take early detection, early intervention in changing the lifestyle. Maybe this is our question for your answer. Is it clearly enough, or maybe I bring to Ms. Novi?
Okay, thank you. And the last question from Mr. Ali. Please, the group can answer the question.
Thank you for the question. We try to answer from a question from Mr. Ali. From our lesson in Thailand and Taiwan for the disaster is mohon maaf saya bahasa Indonesia. Jadi di Thailand dan di Taiwan untuk kesiapan bencananya itu terdapat hubungan yang jelas antara lembaga-lembaga sehingga koordinasi antar lembaga itu sudah terdapat payung hukumnya dan peraturan pemerintahnya seperti itu. Dan menjadi catatan kami di Taiwan itu setiap 21 September itu dicanangkan sebagai hari bencana sehingga setiap pada tahun itu setiap tanggal itu di Taiwan diselenggarakan simulasi untuk persiapan penanggulangan bencana seperti itu.
Excuse me, I want to additional for explanation from Pak Ari. Hospital construction must pay attention to environmental management, must not dispose of waste indiscriminately or green hospital and an early alert system in anticipating natural disaster and fires, especially in evacuating patients, and must not reuse refuse patients. The early warning system for earthquake and fire natural disaster is very important. So it is necessary to program routine training and simulation, not only for security unit officer, but for all staff in hospital, both medical, doctors, and other health workers. So what they are used to do it. And don't panic when disaster strike, like in hospital in Indonesia. Thank you.
Is it clear? Yes. Okay. How Mr. Ali for the question? Is it clear?
Ya, terima kasih.
Thank
Hanya
you.
satu aja nanti kalau ketemu saya, tolong dipelajari soal Hospital Safety Index. Terima kasih.
Yes, thank you. Okay, for the last question from Mr. Fritz.
Okay, thank you, Mr. Fritz, for the question about case manager. Case manager actually is something to coordinate with units and installation who relates to so that the patient service management system can run well. There is conducting coaching, assistance, supervision, and guidance, and evaluation of the case of patient. Usually is a difficult case. In Thailand, we seeing they using information by integration multidisciplinary profession by using the multidisciplinary note. There is a communication between provider of health service, doctors, nurses, or physiotherapists who conduct by some case manager. In Indonesia, actually there is a case manager too, but we are still growing. We are still applicating. Some hospital has case manager, actually nurse or vet or doctor who can conduct the case by using clinical pathway sometime. Or so about the clinical governance in case manager, there is a relation in clinical effectiveness and using information. I think that our answer, Mr. Fritz. Thank you.
It is clear for Mr. Fritz for the question. Okay, thank you. I think we still have more time, so I will open to question. Maybe the audience. If you have a question, you can raise your hand. Okay, for Mrs. Dr. Sabrina.
Okay, thank you for the opportunity. My name is Sabrina Aulia Rahma. I want to ask for group 3. What kind of indicators being used to monitor the quality of service at your hospital? Thank you.
Thank you, Ibu Sabrina. Okay. Any question? Okay, maybe the group will answer the question first.
Okay, thank you. Thank you for your question. I will try to answer to Mrs. Sabrina. Indicator to monitor of the service Teparin Hospital. Next, for hospital level quality indicator, we follow Thailand Hospital Accreditation recruitment, which focus on patient safety, and results are reported monthly to several top quality as well as business meeting. Thank you.
Okay, thank you, Miss Ibu Sabrina. It is clear?
Okay, very clearly. Thank you.
Thank you. Maybe have any question from the audience? No? Okay, Mr. Yunus, please.
Thank you. I have one question. Based on the result of observation and hospital visit interview at Teptarin Hospital and NCUH, what are several things that can be adopted by Indonesia?
What group do you want to?
Thank you, Pak Yunus, for your question. I want to answer your question based on the result of observation and hospital visit interview at Teptarin Hospital and National Taiwan University Hospital. Based on the result, there are several things that can be adopted by Indonesia to turn healthcare facilities into environmentally friendly hospital. What can be adopted from Teptarin Hospital is the principle of healthy at the Teptarin Hospital is a very good concept. In practice, it may be felt that it can be difficult to apply in Indonesia because there are still many Indonesia who don't have the awareness to live in healthy life. And there are no government policies that regulate citizens to better implement healthy living and healthy building in Indonesia. It's enough. Thank you.
Okay, thank you for all questions. Ladies and gentlemen, next the session is discussion with our panelists. To Professor Dr. Ahmad Rudianto, internist consultant, your time is 20 minutes and the time is yours.
Thank you very much for the introduction. And my question is, I'll try to structurize, and then you will understand about the topics what already you presenting. Okay. First, you already presented according to the 5 pillars of clinical government and very clear, good. But my question is, what do you understanding in the hospital sustainability? First, okay. Then we are going the next question or the next comment. Jadi pemahaman Anda tentang Hospital
may I
sustainability.
answer
Okay.
about hospital sustainability? I think there's actually healthcare sustainability. How an hospital creating a way to be sustained, or it can continue serve to the community by generation. So the services has to have an innovation to get what the people needs, then create an innovation what we can service to them. It's first. The secondly, sustainability about performance of finance the hospital. It must be growth. It can be down. So how we make innovation about finance condition. And the third, we have to able to conduct the environment. So what we service it to people is to environmentally friendly. Thank you.
Another comment? Yes, please.
Yes, thank you, Prof. Rudi. I think hospital sustainability is a key of concern for many hospital administration, but implementing green practices while still running inefficient. Patient-focused facility is a challenge. Take a look. Sustainability is so important for hospital because the hospital will striving to develop more eco-friendly practices.
Okay, that's a good. Theoretically is very good. But the next question is, what is the aim of hospital sustainability? The aim. Hospital sustainability. Tujuannya itu apa sih sebetulnya? Hospital sustainability. Everyone can say.
The aim of sustainability is reduce cost, reduce risk, and promote a positive public perception. Simple.
Short sentences.
Continuously services for generation.
Continuous survival of the hospital. Okay.
Yes.
Yeah. So that when the hospital thing have to survive, and then the next step, what kind of the program must be developed?
The next program has
can think through the clinical government.
About the clinical government, the program has to include in the clinical effectiveness. There is some guidance about clinical effectiveness. We use clinical pathway or using guidance. So what some services we give to people, it has to continuously serve or can be used for next step in effectiveness. Secondly, in using information in the clinical governance too, we have to an efficient way to give service to people. And Teplarin, they using friendly some friendly kedekatan.
Tidak apa-apa bahasa Indonesia monggo.
Jadi di Thailand mereka menggunakan kedekatan secara human, jadi dengan seakrab mungkin mendekatkan dengan pasien dan
What do
juga
you,
menggunakan.
what do you think according to the relationship between clinical governance and hospital sustainability?
There is some ada sesuatu yang kita lakukan di clinical government itu yang bisa kita kaitkan terhadap keberlangsungan dari layanan rumah sakit.
So you mean that you must implement clinical government as good as possible?
Yes, some
Yeah,
synergy
okay.
in collaboration.
Yes. So I hope that you understand according to the relationship between the two kind of the aspect. The important thing is when you are going to place of the first objective of your activity, and you think about the first objective you have to decide before you going to some place.
Actually, we have to kita harus melihat dulu, Pak. Kita harus cek dulu apa yang sudah kita lakukan yang belum sesuai.
Kalau ada suatu tempat,
Tujuan, aim.
Did you see the differences between Tatarin and the Taiwan hospital? According to the aim, objective of the services of them.
Yes. Actually, in Tatarin, mereka ingin lebih mengubah gaya hidup masyarakat. Bagaimana masyarakat itu mengenali kebutuhannya tentang tanda gejala diabetes, kemudian bagaimana menjaga pola hidupnya. Tatarin ini menyediakan sebuah pelayanan yang sangat inovatif seperti gym, seperti kantin sehat, seperti jadi.
What is the aim of the Tatarin Hospital? What is the objective? The important objective of the Tatarin. You already mentioned in this paper.
The mindset.
No. Tatarin is very unique hospital, and they focus on
lifestyle. The changing of lifestyle. No.
itu bagian dari nanti karena fokus itu tadi. Loh, standar seperti sehingga nanti desainnya semua itu ngikutin ini tadi. Kenapa tangganya dihitung, kenapa ada tulisan untuk mengubah lifestyle itu diimplementasikan dengan tangga itu, naik tangga itu dihitung berapa kalori tiap tangga itu. Jadi fokusnya Tatarin itu di endokrin, khususnya diabetes. Khususnya diabetes. Sehingga dia desain rumah sakitnya itu kemudian ditujukan untuk semua pelayanan diabetes itu membutuhkan apa saja. Untuk lifestyle-nya apa, untuk pelayanan yang geriatrik dengan diabetes gimana, untuk yang apa itu, jadi semua seperti itu. Nah, oleh karena itu saya tadi tanya, what is the important one of the the first step of the hospital sustainability program? Focus. Also in the Taiwan, you already mentioned that they focus on the geriatric patient. The next question. Who responsible for the implementation of the hospital sustainability? Siapa yang bertanggung jawab pelaksanaan hospital sustainability?
Manajer hospital.
Manajer.
Iya, top manager.
Hospital management and professional.
Hospital management and professional. Okay. And then when you think that my hospital have to sustain,
Yes, sir.
you have to focus in one area. Let's say diabetes.
Oh, yes.
Okay.
This is on diabetic.
Yeah. The next step, you must think about what kind of thing you must think. Setelah Anda menentukan fokus, terus berikutnya untuk sustain loh ya. Oke, program. What kind of program? Or maybe you must think according to when you try to develop the programs. What kind of thing you must try to find out before you decide the program. Loh, supaya ngerti, supaya nanti Anda nggak sekedar nulis saja. Kenapa kemudian di sini Anda tulis di halaman berapa itu tetap B1 itu ada perbedaan antara Taiwan dengan Taptarin. Oke.
Keterlibatan pasien and family.
Lihat persaingan dulu, lihat sudah kan? Oke, ini saja dah biar nggak Anda atlet lari, Anda juara 3. Ya. Anda
Kebutuhan, Mbak. Research to practice, practice to research. Yes.
Nah, saya nggak di situ. You have to know well according to your competitor. And then you focus on, tadi sudah milih diabetes. And then fokus berikutnya. Ya, kan Anda mau nyusun program. Jadi Anda ngelihat pesaing. Terus habis itu Anda fokus kemana? Ini supaya Anda terlalu bingung ya. Anda pikirkan Anda masuk ke swasta deh. Supaya survive. Pasar kan, Anda kan merebut pasar kan? Merebut pasar. Nah ini ada pesaing Anda. Jadi Anda harus melihat apa?
Quality improvement.
Anda segmen, setelah segmen Anda need dari segmen. Need dari segmen. Nah, ketika maksud saya gini loh, Mas. Saya pergi ke Taptarin atau virtual atau apa saja. Kemudian saya ingin belajar tentang hospital accessibility dan clinical government. Sebelum saya ngeksplor data, belum saya pergi ke selancar di internet, saya sudah punya pikiran apa sih sebenarnya yang harus saya munculkan di dua keyword ini. Saya harus tahu persis clinical governance. Anda sudah mendefinisikan dengan bagus sekali tadi 7 pilar. Cuma kemudian yang Anda fokus berikutnya yang sustainability, Anda melihat cuma definisinya saja, tapi makna hospital sustainability belum ada di situ. Dan saya katakan ini untuk kehidupan kelangsungan hidup rumah sakit. Nah, sekarang ini rumah sakit. Anda hidup di suatu lingkungan rumah sakit bukan sendiri. Ada rumah sakit lain. Anda bersaing di situ. Ya kan? Nah, sehingga ketika saya berselancar di internet, saya tahu di mana ya clinical performance itu ditetarin, kemudian setelah Anda dapat datanya, kenapa kok begitu? Anda kaitkan dengan fokusnya. fokusnya Taptarin apa, fokusnya di situ apa. Baru Anda paham tentang kenapa dua ini disuruh muncul di apa namanya, dimintakan Anda nulis ini gitu. Nah, kalau ini ya memang data, tapi kemudian kesimpulannya apa sih? Tadi Anda sudah kesimpulan, tapi sebetulnya makna kesimpulan dari Anda belajar ini apa sebetulnya? Makanya tadi ada yang tanya, apa sih hasilnya Anda belajar mempelajari dua rumah sakit ini? Sebetulnya yang ditanyakan, apa sih yang Anda pelajari dari clinical government di dua rumah sakit ini? Sebetulnya gitu. Dan untuk kita apa yang bisa kita pelajari? Fokus bisa kita pelajari. Kemudian pengembangan nanti kaitannya dengan pengembangan rumah sakit dengan sendirinya. Karena kalau geriatrik hospital dengan diabetes hospital pasti beda lah. Tapi ada dasar-dasar yang sama. Ngerti maksud saya ya, Mas? Sudah ada komentar nggak? Silakan. Atau Anda tanya, monggo. Anda tanya, silakan. Saya itu terus terang membayangkan, saya sering ngomong sama Olipan. Anda nanti sekolah lulus dari sini harapan saya, Anda bisa membuat forecast untuk rumah sakit. Ke depan rumah sakit itu lihat apa ini sih? Karena saya harus hidup rumah sakit ini. Bukan hanya profit ya, tapi kita bertanggung jawab kepada kelangsungan berbagai staf yang butuh kehidupan kan. Kan itu. Jadi kenapa sih Taptarin dibuat begitu? Karena dia fokus pada pelayanan diabetes dan endokrin, sehingga nanti pengembangan laboratoriumnya pasti menuju ke sana. Enggak laboratorium yang umum-umum, enggak terlalu mahal. Kemudian apa namanya, rehabilitasinya juga fokus pada itu, sehingga tidak mendatangkan untuk macam-macam gitu. Nah itu harapan saya sih Anda sebetulnya memahami dulu sebetulnya aim atau makna daripada hospital sustainability itu apa. Terus kemudian bagaimana clinical government itu menunjang untuk sustainability. Ya. Menunjang untuk hospital sustainability. Tapi sebelum untuk hospital sustainability ini kita berpikir bahwa saya pada kedudukan persaingan. Maka saya harus tahu tentang kekuatan tanda petik pesaing saya, apa difokuskan dia, bagaimana melebihi dari dia. Mestinya gitu. Sehingga kita bisa tetap survive. Jadi saya ingat betul ada tulisan Anda itu untuk mempertahankan kedudukan Anda yang sekarang. Itu harus, kalau ini pelari harus sehari lari berapa kilometer gitu. Latihan untuk mempertahankan kedudukan sekarang, belum untuk naik dari 3 ke 1 tadi. Ya. Sementara itu dulu. Nanti kalau mungkin saya cuma mendorong Anda berpikir dulu maknanya masing-masing, kaitannya apa. Kemudian kalau ini sustainability itu sebenarnya apa sih sebenarnya? Kan intinya bahwa saya
Terima kasih, Prof. Terima kasih.
Thank you, Prof, for the feedback. Okay, the next panelist is Mr. Tito Hari Pradianto, STMT. Your time is 20 minutes, and the time is yours.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to congratulate this group for having completed the test well, quite well. Like Prof. Rudi, I also want to ask before starting the discussion. And like Prof. Rudi also, I want to use this opportunity to use bilingual, yeah, English and also Indonesian. Okay, I would like to ask each and every one of you, yeah, person to person, door to door, mouth to mouth, yeah. What, in your opinion, what is the concept of sustainability, in your opinion, yeah, in healthcare facilities or in hospital architecture? But mention in only 3 words: A, B, C. Please, anybody, please.
Eco-efficiency.
Okay, eco-efficiency, then okay, thank you, have a good day. Anyone?
Healthy safety.
Excuse me? Eco-efficiency, and number 2, safety.
Keselamatan, safety.
Yes.
Terus kemudahan.
Okay. Accessibility. Yeah.
Kenyamanan.
Economy. Yeah. Okay. If I'm not mistaken, in my lecture with all of you in 2 weeks ago, this has been explained. Yeah. I repeat what I'd say in this lecture. Number 1 is economics. Number 2 is ecology. Number 3 is social. Economics is low cost building, low cost human resource development, human resources salary. For ecology, it's good environment. For social, is human movement, circulation, and yes, accessibility. So the domain of sustainability is those 3. Yeah. But in the paper, you all mention a great concept about sustainability in hospital architecture, which is a healing environment. But unfortunately, you did mention the principles of healing environment. Yeah. As I know, there are 8 or 10 principles about healing environment in some books. I can give you the reference if you need that. So you can use all those parameters to evaluate or observe the Taptarin Hospital or the National Taiwan University Hospital. Because the basic algorithm of activity and observation and evaluation is using the parameters to research or to evaluate or to observe. Yeah. So the key is the parameters. What time do I have, Miss Holly? What time do I have? Oh. So I guess this time is for Indonesian. Baik, saya ulangi lagi ya Pak. Jadi intinya 3 poin tadi, di 3 poin tadi dinilai dengan 8 atau 10 parameternya healing environment. Nature, lighting, apa. Sehingga dengan parameter ini kita punya pegangan untuk mengevaluasi sekualitatif apapun kegiatan riset yang kita lakukan. Saya lihat di 5 kelompok tugas ya, tugas yang dikumpulkan, itu hampir tidak ada yang menggunakan parameter. Disebutkan, ada yang disebutkan, tetapi tidak dipakai. Yang lainnya malah tidak disebutkan dan tidak dipakai, apalagi yang disebutkan agenda, apalagi. Jadi, healing environment ini adalah konsep yang bisa kita pakai untuk mengevaluasi, sekaligus bisa kita pakai untuk merencanakan. Contoh aja, ini saya sedang membuka juga healing environment ya. Contohnya tentang spatial layout atau layout spasial atau layout ruang. Layout ruang itu di sini disebutkan having a room for their own. Jadi ini adalah salah satu parameter. Whatever yang mereka sebutkan di buku itu sesuai atau tidak kondisinya dengan di Indonesia. Tapi Bapak Ibu sekalian ini sudah menggunakan healing environment as a parameter to evaluate. Jadi ya dipakai. Padahal kalau kita lihat having a room for their own di sini untuk kelas 3 atau kelas 2 nggak mungkin, Pak. Apa anak rumah sakit meskipun ada ya, meskipun ada. Jadi saya pernah mendesain sebuah klinik di Lumajang, itu klinik rawat inap cuma 10 TT, si direktur apa ya istilah kalau klinik itu direktur atau penanggung jawab klinik ya, alumni sini juga, itu beliau mau menerapkan one room for one bed. Meskipun kamar mandinya di luar. Ya, jadi artinya healing environment ini secara konseptual bisa kok dilaksanakan. Meskipun mungkin dalam konsep yang lebih sederhana. Nah, baru parameter spatial layout yang kedua atau yang B adalah bathrooms. Sama juga. Bathrooms ini juga patient privacy increase when they have a private bathroom. Jadi kalau satu kamar, satu pasien, satu kamar mandi sendiri dalam. Dia nggak bilang harus di dalam sih sebetulnya, private bathroom itu bisa di luar sebetulnya, tapi kuncinya di bawah pasiennya misalkan gitu. Jadi itu juga bisa. Gitu. Jadi kalau kita sudah bersepakat untuk menggunakan satu parameter, maka parameter ini dipakai betul. Permenkes misalkan, meskipun sama Menkes sudah dicabut ya, Permenkes 24 tahun 2016 itu sudah dicabut, digantikan Permenkes 21, Permenkes 14 ya, 14 2021. Yang ternyata isinya itu tidak bisa menggantikan Permenkes 24. Kalau mau pakai itu, ya sudah, semua parameter yang ada di situ dituliskan, kemudian dipakai untuk alat untuk mendesain, mengevaluasi. Apakah hasil evaluasinya nanti akhirnya skornya di bawah semua, di skala Likert gitu ya misalkan, itu akhirnya skornya di bawah semua, nggak masalah. Yang penting kemampuan Bapak Ibu sekalian dalam melakukan evaluasi menggunakan parameter. Jadi jangan pernah melakukan evaluasi tanpa berangkat dari sebuah parameter, karena itu nggak fair banget. Atau kalau bahasa ilmiahnya mungkin kurang ilmiah ya, kurang ilmiah. Jadi kurang lebih seperti itu. Ya. Sama juga seperti Prof. Rudi, mungkin ada yang mau ditanyakan sebelum saya. Ya, seperti kemarin itu tugasnya kelompok 5 kalau nggak salah. Saya nggak tahu kelompok 5 ada di sini enggak orangnya. Yang operating theater ya, di rumah sakit RSI Aisyah ya. Tidak ada pembahasan tentang arsitektur rumah sakit jelas. Tidak ada sama sekali. Padahal MOT atau modular operating theater di Malang Raya tidak ada yang sesuai dengan standar. Sama sekali, swasta ya. Sama sekali tidak ada yang sesuai persis dengan standar. Tidak ada. Yang nggak sesuai standar kenapa? Loh, banyak. Kalau pemerintah banyak. Banyak itu rumah sakit di Malang no piro. Siji loro telu. 4 namanya ini, RSUB. Nah, seperti itu kan apakah benar-benar tidak ada poin masukan atau evaluasi untuk modular operating theater-nya itu. Entah sirkulasinya, entah itu loh. Jadi selalu ada poin-poin itu di kelas yang lain, di kelompok yang lain, kalau enggak salah kelompoknya Pak Yunik. Bukan. RSAU Efram. Oh, oke. Ya. RSAU Efram ini malah permasalahan utamanya adalah pasien osteoartritis. Tapi di identifikasi masalah arsitektur rumah sakitnya adalah toilet yang kurang bersih, coba. Kira-kira korelasinya apa gitu ya antara jadi kalau misalkan misal nih, jadi based on data, tadi seperti yang dikatakan Prof. Rudi, bagaimana mempertahankan posisi atau bagaimana positioning rumah sakit kita terhadap rumah sakit yang ada, itu kan butuh data. Sebagai contoh ya, saya untuk menentukan jumlah tempat duduk di ruang tunggu saja, saya harus meriset atau mencari data 5 tahun ke belakang tentang kunjungan pasien rawat jalan. Berapa? Terus mari ngono, belum selesai, diproyeksikan sampai 10 tahun ke depan. Nah, di tahun ke-10 hasil proyeksi ini, itu berapa jumlah pasiennya, jumlah kunjungan rawat jalan. Langsung baru kita bisa menganalisis, kita menggunakan asumsi, misalkan instalasi rawat jalan buka selama 8 jam. Itu sudah perlu dibagi, jumlah kunjungan pasien rawat jalan, perharinya berapa, dibagi 8. Berarti ketemu per jamnya, pasiennya berapa. Segitulah jumlah tempat duduk yang harus kita sediakan. Itu kalau asumsinya satu dokter itu menangani pasien maksimal 1 jam selesai. Kalau seperti dokter Tatong ya enggak selesai 1 jam. Apalagi kalau pasiennya lansia, itu bisa 2 jam atau 3 jam. Jadi sak ngobrol-ngobrolnya, satu paket dengan ngobrol. Nah seperti itu kan harus based on data, tidak ada masalah. Yang penting kita menentukan sesuatu yang mengevaluasi untuk menentukan langkah berikutnya itu berdasarkan data. Kayak gitu. Ya, jadi sama juga kelompoknya RSI Unisma ada ya? Oh Unisma, oh ya Unisma. Kurang nyamannya fasilitas rumah sakit, tapi jawabannya kurang maintenance dari pihak rumah sakit. Yang mana yang benar kurang nyaman? Artinya kalau kurang nyaman itu bukan masalah maintenance, tapi masalah pengadaan. Saya memang ke ICU kan ini ya. Saya 2 hari yang lalu saya ke ICU-nya RSI Unisma. Memang tidak ada ruang menunggu untuk keluarga, tidak ada memang. Jadi di situ ada kursi tunggu. Nah, keluarga pasien itu tidurnya di baliknya kursi ruang. Ya itu aja difoto, terus disandingkan dengan parameternya. Ada nggak ruang tunggu keluarga pasien? Harusnya ada, di sini tidak ada. Selesai. Jadi step berikutnya jelas. Saya harus mengadakan ruang tunggu. Ya. Terus kelompoknya Pak Unix, kelompoknya Pak Unix itu Permenkesnya kelamaan, Pak. Permenkes 30 tahun 2019 itu sudah diganti beberapa kali sudah. Ya, mungkin beliau terlalu lama di psikogeriatri ya, jadi kurang update. Ya, itu. Kemudian yang agak paling lumayan ini kelompoknya rumah sakitnya Dokter Sadi. Tidak hadir ya? Oh, ada. Ya. Ya. Artinya itu lumayan nggak bagus dibandingkan yang lain gitu loh. Enggak apa-apa. Cuman memang paling sedikit masukannya memang paling sedikit memang yang rumah sakit Prima Jada masukannya paling sedikit. Tapi ada sedikit catatan ya off the record. Rumah sakit itu dulu yang desain saya. Jadi makanya enggak ada masukan. Iya. Betul ya. Sedangkan Efrem dulu sudah hampir kerjasama enggak jadi, makanya masukannya paling banyak. Sama-sama. Senang bisa membantai. Ya, baik. Jadi di laporan nanti kalau memang ada revisi, mohon dituliskan secara detail tentang parameter yang digunakan. Whatever yang mau pakai healing environment kah, Permenkes kah, dan Bapak Ibu sekalian bisa punya kebebasan untuk membatasi parameter mana yang tidak digunakan. Dengan alasan yang monggo dicari-cari sendiri lah yang rada ilmiah gitu ya. Supaya at least kita sudah melakukan satu aktivitas evidence base ya, upayanya menuju ke arah sana. Mungkin dari saya itu dulu, waktu saya kembalikan ke terima kasih.
Thank you, Mr. Tito, for the feedback. Well, of the second session, this seminar are first, the approach of hospital sustainability aspect of. Oh.
Ya, jadi saya cuma pesan aja ya. Only to give you some according to the how we try to explore related to the some problem, some topics. Okay, this. Pertama pahami dulu sebetulnya maknanya apa sih keyword. Kemudian ini kan sudah relationship between two kind of the topics, clinical government, and then the second is hospital sustainability. You must think according to the relationship between two. Apa sih saja nih hubungannya itu apa? Nah, kemudian indikator apa yang harus kita lihat untuk clinical governance, indikator apa yang harus kita lihat untuk clinical hospital sustainability. Nah, dari situ kemudian kita ekspor ditatarin sama Taiwan. You already mentioned in table 1 related to 7 pillars of the clinical governance, both of hospital, but actually you don't think any conclusion. Anda hanya nampilkan aja dua ini beda. You never ask according why difference. What's kind of reasoning for the differences? Alasannya apa ini kok berbeda? Nah, jadi kemudian dari situ maka Anda bisa belajar sebetulnya banyak hal dari akses Anda itu. Itu kan data sekunder kan. Data sekunder toh. Tapi seperti penelitian kalau data sekunder bandingkan harus ada indikator yang pemutusnya. Oh, ternyata ya memang ada beda. Bedanya kenapa? Satunya fokus dengan diabetes, satunya dehidrasi, satu. Oleh karena itu mungkin nanti sistem juga beda. Alurnya beda, segala macam beda. Hospitalnya juga beda, layoutnya. Gitu. Jadi sebetulnya ini suatu kajian yang bersama antara dua yang diajukan tadi. Dan mestinya saling bantu. Kenapa sih tatarin kok dibentuk seperti ini? Kenapa yang situ kayak gitu? Nah, itu kan dibicarakan mulai dari fokus dari masing-masing hospital tadi. Terus kemudian setelah fokus budaya kerja masing-masing beda pasti. Kan orang Thailand dengan orang Taiwan pasti beda lah. Nah, itu akan mempengaruhi sistem organisasinya dan kemudian proses organisasinya. Itu sebenarnya saya bayangkan ketemunya kayak gitu. Tapi hanya memunculkan data, ujung-ujungnya apa? Pemerintah sih konten. Iya kan? Kesimpulan Anda kan pemerintah Indonesia seharusnya ngasihkan ini ABCD. Dan mestinya kan hospital itu bagaimana bereaksi terhadap data ini. Itu bukan, iya ada aturan kok pemerintah iyalah misalkan, tapi kemudian kalau misalkan saya swasta menanggapi masalah BPJS itu, reaksi saya gimana? Apakah saya mau menerima untuk rawat inapnya atau enggak? Kan kajian. Apakah saya cuma rawat jalannya aja yang saya terima? Ya enggak apa-apa. Tapi kemudian kita yang untuk apa? Untuk rujukan kelas C atau B atau apa gitu kan. Jadi maksud saya Anda nanti akan memegang rumah sakit dan setiap eksternal faktor itu harus Anda kasih satu-satu sehingga kemudian Anda bisa mengendalikan rumah sakit itu dengan baik. Karena enggak mungkin Anda cuma memperbaiki rumah sakit itu enggak ngerti tujuannya kan susah. Nah, mungkin investing ya, investing. Nah sekarang kan, coba sekarang, berapa bed yang idle di Panti Nirmala, di RKZ, yang Persada, berapa yang lain? Karena semua mengambil segmen yang sama. Enggak ada fokus sama sekali, enggak ada fokus. Semua ya, iya, pelayanan sama. Nah itu maksud saya supaya Anda berpikir alternatif supaya kemudian Anda menjadi inovator lah, kreatif, berpikir kreatif sehingga kemudian Anda bisa mengendalikan rumah sakit dengan baik. Kalau saya tanya misalkan ya, kalau Anda suruh milih, Anda bisa mendirikan klinik swasta, klinik pertama, tipe C, tipe B, tipe A, pilih mana? Pilih mana coba? Itu kan membutuhkan pola pikir yang dikatakan tadi, saya harus belajar kiri kanan. Mempelajari kiri kanan, sebetulnya daerah, katakan Sumbersari ini butuh apa sih? Oh cukup Pratama, ya jangan bikin yang wis. Iya kan? Udah kursi gede, nggak ada isinya, nggak ada pasien. Itu yang maksud saya itu, tolong pahami dulu. Sebetulnya klinik kergapan, hospital sustainable itu apa? Klinik kergapan itu perannya di mana? Kemudian Anda membandingkan dari rumah sakit, kenapa kok beda sih? Pasti ada hal yang bisa dijelaskan di situ. Mesti gitu nih. Ya, masih. Terima kasih.
Jadi tipsnya dipahami the whole konsepnya tentang sustainability. Mungkin kalau yang rumah sakit pemerintah harus angel ya. Soalnya wis sustain ya. Pasti pasiennya berapapun sustain ya. Dan coba disimplifikasi permasalahannya, bukan memandang remeh ya tidak, tapi coba disederhanakan dengan bahasa yang sederhana sehingga tidak berat ya. Ini satu contoh aja. Saya waktu mendesain master plan untuk rumah sakit Kristen Mojowarno, pada saat saya terlibat di pengerjaan master plan itu, Mojowarno langsung membuat 12 klinik Pratama. Jadi master plan jadi klinik running. 12 dengan nama yang beda-beda. Tapi semua ownernya adalah Mojowarno. RS Kristen Mojowarno. Beda waktu saya mendesain rumah sakit Rajiman, Gede Diningrat. Begitu saya mau presentasi master plan, 12 orang keluar dari ruangan. Ya karena kerjanya terlalu banyak. Sehingga nggak fokus ya. Artinya begitu. Jadi dan itu tidak bisa digeneralisir. Karena permasalahan tiap rumah sakit berbeda. Standar kita mungkin pakai satu standar. Tapi permasalahan tiap rumah sakit beda-beda. Bangil, begitu ngubernya beliau untuk dari rumah sakit C ke tipe B. Begitu nyampe B, Rasulullah, Pak pasien saya tinggal 30%. Mojowarno ngempet-ngempet, sudah ada spesialis uronya, diusir-usir. Soalnya dia takut naik ke B. Jumlah TT-nya dimepetkan 199 TT. Kalau nambah satu lagi dia sudah jadi B. Jadi begitu. Ini poinnya akan banyak sekali juga untuk dokter Dwi, guys, melirik-melirik dokter Dwi. Ya, jadi saya juga seringkali menyampaikan ke beliau, setiap kali mengambil keputusan di fasilitas kesehatan, itu selalu didasari. Nggak usah yang berat-berat lah. Beli apa namanya, CT scan misalkan. Jumlah pasienmu piro? Saya sering nanya sama dokter-dokter spesialis SPOG. Sampean lu kate gawe infertility lho, pelayanan infertility lho. Pasiennya piro? Pelayanan infertility. Pin center juga ke dokter-dokter anestesi. Sampean lu kate gawe pin center lho, pasiennya piro? Wis tak pokoknya butuh Pak Ibu. Butuh, tapi investasinya nggak main-main ini. Cat lab apa segala macam. Berapa pasiennya? Makanya terakhir waktu di dokter Iska, saya nanya sebelum bikin cat lab. Tolong tunjukkan saya data. Belum ada data, saya nggak mau bantu desain. Begitu ditunjukkan data, saya oh iya ini akeh memang pasien jantungnya. Sudah, kita bikin cat lab. Jadi memang semuanya based on data. Jadi cuma jangan dipikir berat, disimplifikasi saja. Iki, wis nang dimarekno iki telu. Ku ono maneh, predali maneh gitu. Ya, mungkin dari saya itu saja. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you for the feedback. Okay, well, the conclusion of the second session, this seminar are, first, the approach of hospital sustainability aspect of hospital design in both hospital, namely the design of building and the hospital environment has an impact on the use of resources in the hospital. Second, the implementation of clinical governance in Thailand and Taiwan has the advantage of engaging patient services, patient need, and providing sustainable service and combination of digital. Hopefully, the presentation will give benefit for us. Thank you for your attention. Thank you for all panelists, presenter, and audience for attending this session. Back to you, Ibu Sabrina, as the MC. See you later.
Thank you, Ibu Chandra Novi Darmawan, for leading the presentation and discussion. It has been very sophisticated, and again, I'm very sure that the feedbacks from the panelists are very advantageous for our improvements. Ladies and gentlemen, now we come to the end of the event. As the representative of the committee, we would like to thank you very much for your attention, active participation, and also valuable contribution during the discussion. I'm Sabrina Aulia Rahma, the MC. Good afternoon and wassalamualaikum warahmatullahi wabarakatuh.